There we go. I'd like to thank you guys all for coming out today. We're very grateful for your turnout, as well as for our presidency, as well as Dr. Fitzer for being here. We have a wonderful presentation today by Jason Stevenson, but first I'm going to introduce Dr. Carla Trentleman. She's probably the person who got me into doing a lot of my volunteer work. She's a sociology professor here at Weber State. She's been teaching since 2008 up here at Weber State, and in the fall of 2009, Dr. Trask, our former pre-med advisor, approached her to do a similar presentation to this on the Affordable Care Act, but it hadn't yet passed, so it was in the debate stage. And so I'm going to allow her to introduce Jason Stevenson, who she put us into contact with. So if it wasn't for her, we wouldn't be able to have this wonderful meeting. Dr. Trentleman.
Good afternoon. It's really a delight to be able to be here. What ended up happening from that introduction between Dr. Trask and myself was that at the time I was the advisor of the Social Club, and Dr. Trask was the advisor of the Pre-Med Club, and we decided that it would be far cooler, because this was the fall of 2009. If you think about the ACA, if you know your history, fall of 2009 was when things were getting really, really ugly with all the debates about whether it should pass or not, whether, all of that kind of jazz. And so Dr. Trask and I and the Pre-Med Club and the Social Club not only did a presentation, we actually put together a series of presentations on healthcare reform. We had 3 presentations in the spring, or in the fall, and then after it passed in the spring, we all decided, yeah, we got to do one more. So we did one more in the spring after it passed. As a part of doing that series, I had the delightful opportunity to become familiar with Utah Health Policy Project. And trust me, they rock. At the time, Judy Hillman, who was one of the co-founders of that organization, came and did one of the presentations, one of the chunks of the series in the fall, and then she also, along with a couple of other folks, came and did the spring presentation for us. I was very, very impressed with the material that they presented, but I was also really impressed with what else I was learning about UHPP. I have tremendous respect for them. They have been working on these issues since well before the ACA passed. In fact, they were working with our state legislature here in Utah on establishing a statewide market exchange before the ACA even passed. In fact, they were approaching the state legislature basically saying, we have no clue if this thing is going to pass or not, but we have some problems in Utah that we really need to be addressing, no matter if it passes or not. And they actually managed to get the state legislature to be willing to have that conversation, which is pretty outstanding. Their website is a great place to find really current information on issues about healthcare reform. In fact, I'm teaching medicine and healthcare and society right now, and most of the readings that my class is going to be using next week in class come from their website. So really excellent organization. And Jason Stevenson is the guy who gets to take credit for that part, for the website and all of that kind of jazz, because Jason Stevenson is the Education and Communications Director at the Utah Health Policy Project, where he edits the Health Matters newsletter and organizes the statewide Health Reform 101 presentations like this one today. Jason is a former economic development consultant and editor at Outside and Backpacker magazines. Jason and his wife Jackie, who is a family doctor, live in Salt Lake City. And with that, let's welcome Jason Stevenson to Weber State.
All right, can you all hear me pretty well? Great. Thank you very much for having me come out to Weber State. It's my first time on the campus. Can everyone hear me in the back? It's all good? Okay. We don't have a wireless slide changer, so Jason has volunteered to help us out. So I'm just going to wave over at him every once in a while. I guess we can go to the first one right now. We've got a lot of things to talk about. In fact, I pulled out some really special slides just for you that we don't normally use in our health reform presentations we do around the state. Primarily because this is a topic that is not only interesting in an academic sense to you, but perhaps also in a career sense as well. How is health reform going to affect what my job's going to be like, what my income's going to be like, where I'm going to be working in the next 10, 15 years. So I added some details there. You can see we will cover the basics. What is the ACA? What's happening here in Utah with regard to health reform? Inside Utah's insurance marketplaces, we're going to get inside the machine. We're going to look inside the website. We're going to look at that crazy website. We're going to look at the options that people have here in Utah when they're going and searching for insurance. How much it costs, what it looks like, what kind of providers are providing this insurance. And then we'll look at the health reform and health careers. How is health reform going to impact folks who work in any kind of health reform, not only doctors and nurses, but folks who work in education side of health and sort of mental health specialties and so forth. We'll take a look at navigators and enrollment. How are people signing up for this insurance? We have some new data on that just from this week. And then finally, if we have time, we'll get to the major public policy decision facing Utah right now, which is about Medicaid expansion, whether or not to expand Medicaid, which is a health insurance for low-income people, to a bigger swath of our population. And that's really what the legislature is going to be dealing with and the governor over the next couple of weeks. Go to the next one. As Carl mentioned about UHPP, we are a nonpartisan, nonprofit organization. We've been around almost 8 years here in Utah. We're homegrown. We're not a part of any national group. And we've been working on health reform going way back. I mean, for the past couple of years, we have been focusing on bringing Obamacare, the Affordable Care Act, to a soft landing here in Utah. That's been our major focus. But we've dealt with a lot of other issues along the way. We're on the web, healthpolicyproject.org, on Twitter, we're even hip like that, and on Facebook. We put a lot of information out there. We have a lot of policy research we do, a lot of coalition building and organizing, especially gearing up for the legislative session, which is occurring, of course, later, early next year in January. We do a lot of work up at the Capitol in Utah. So we can go to the next one. Before we get started, though, I wanted to kind of touch on the dashboard. This is what we call the important information you need to know about the Affordable Care Act. And this is probably for just talking with your friends, talking with your family. People probably look to you guys as experts in healthcare issues because this is what you study, this is what you're focused on. So here's some information that you can share. We all know that the Affordable Care Act is also called Obamacare, also called the ACA. I use all three terms. Feel free to use whichever term you like. People could start signing up on October 1st, just about a month and a half ago. And that open enrollment period goes from October 1st to March 31st, signing up for these new insurance options. We'll talk about how that happens in a little bit, but I wanted to give you the dates. The insurance starts on January 1st. That's the earliest it can start, New Year's Day of this coming year. But if you want that insurance to start on January 1st, you have to sign up by December 15th. If you sign up on December 20th for this insurance, it's not going to start until February 1st. The 15th of the month is the cutoff for having your insurance start the 1st of the next month. So if you sign up on January 10th, your insurance starts February 1st. If you sign up on January 18th, your insurance will start March 1st. So that 15th of the month is an important deadline to consider, especially if you're trying to time coverage to kind of kick in right when some other coverage ends, which is how most people are going to be doing it. So those are the dates, the things to keep in mind. Open enrollment next year is going to be a lot shorter. It's going to be from October 15th until December 7th. So very much tighter open enrollment period for everybody to kind of jump in and get this new insurance. Guess we can go to the next one. Now, these are the numbers that came out this week. You might have read some news articles about how many people were actually signing up for Obamacare on healthcare.gov. And the numbers are not very good. And a lot of that is because the website has been so abysmal for the past month and a half. Look at this one over here. The number of Utahns who have selected a plan is 357 in the first month of open enrollment. That's the number of people who have actually gone in, either put a plan in their shopping cart or actually paid for it and bought it. So 357. I think they thought that number would have a couple more zeros after it when they were trying to launch this thing, not just be that small. But if you actually look at the rest of the numbers, you see, there's 9,000 people who have completed an application and are eligible to buy the insurance here in Utah. And actually about almost 4,000 who are eligible for these new premium subsidies, which I'll talk about. So there's a lot of folks in the pipeline who just haven't actually gone ahead and bought that plan. So Although 357 is a pretty disappointing number, there are thousands that are still, in the shopping experience, and probably many more who are just waiting for those deadlines to get a little bit closer. I mean, the way I like to talk about it is how many people do you know have bought all their Christmas presents yet? Not too many. We tend to wait for the last minute when we do this kind of thing, and the same thing applies to insurance based on the experience of Massachusetts, which pioneered this a couple of years ago, and other states as well. So, disappointing numbers for sure, but we're optimistic that they are going to get better as more people sort of actually choose and buy their policies. Thanks. And here's one reason why those numbers are pretty bad. These are some other abysmal numbers. This is a survey the Kaiser Family Foundation does about what people think of the Affordable Care Act, what they think of Obamacare. It has never been more popular than 51%, going back the last 3 years. Currently in October, it's 38% favorable. Now, we could say it's more favorable than Congress, but there's things you scrape off your shoe that are more favorable than Congress these days. So it's really had a public relations disaster. Even the people who are supposed to benefit from it don't like the Affordable Care Act. And actually it's funny because they usually don't like Obamacare and they like the Affordable Care Act. They don't realize it's actually the same thing. So there's a lot of misinformation, there's a lot of education deficit that we're facing. And one of the things is that for most of this time, the Affordable Care Act was a theory. It had some impact, it was happening a little bit in people's lives, but it was something that was going to be happening further down the road. And the one thing we know about Americans is that we really don't like things when they're a theory. It's only once they become a part of our fabric, of our culture, or how we do things, that we start to really understand them. We're kind of late adopters in that regard. So these numbers, as bad as they are actually pretty predictable if you looked at other social programs from Medicare Part D, launched in 2006, to even going back to Social Security and Medicare. People don't like things they can't actually touch and feel. And so really Obamacare is something that people are only just starting to touch and feel at this moment. So again, horrible numbers. If I was a public relations agent and Obamacare was my client, I'd be really, really upset right now. But we think that those numbers are probably going to be going up as more people start to realize what it actually is. Start to get the facts about it as opposed to a lot of the misinformation that's been out there. We jump to the next one. And here's one reason why sometimes what used to be doesn't always have to be the case. Look at this ad. More doctors smoke Camels than any other cigarette. This used to be in magazines across the country. Can you imagine an ad like this appearing today in our society? Things change. Healthcare policies change. People's expectations about what is good and what is bad have definitely shifted over time. So if you think that everything stays static and stays the same, all you have to do is think of this ad. And I put this up here because I want to look at what life was like before the Affordable Care Act. Actually somewhat like the current system we're in right now. We can jump to the next one. The United States has a great healthcare system. We cover, we do some really good healthcare here, but we also pay quite a lot of money for it. We're number one in the country, or number one in the world, and especially among other developed nations in what we pay for it. So we have good healthcare, but we pay for it, quite more than many of the other countries out there, including countries that don't necessarily have nationalized healthcare. Countries like Switzerland or Germany have kind of dual systems there. So we often hear the U.S. does have great healthcare, and it does, but we have to realize that it comes with a price tag that is also pretty high. Jump to the next one. The problem is that even though we pay so much for our healthcare, our health outcomes aren't so high. We actually don't rank as well as a lot of the other industrialized countries in some some common things like heart attack, life expectancy, infant mortality. Part of it is that we have a pretty diverse and big population compared to other countries. And some of it is that our healthcare is really good in some parts of our country and really bad in other parts. Or people who don't have access to our great health care end up having these kind of bad health outcomes, more so than people who do have access to it. So we've got a bit of a spotty system in terms of, we pay a lot for it, but maybe we're not getting the best result out of it. It's kind of like you go to a really fancy restaurant and you order the steak and it costs $80 and it comes out and it's completely charred. Why do you just go and spend $80 on a steak that is inedible? Well, in some cases, that's kind of like what our healthcare system is. We pay the most, but we're not getting, the prime rib. We're getting something a little bit more like Spam in some cases. So something to keep in mind. One more slide. And then one reason why we do have so much expense in our healthcare system is we tend to pay more for the same things. If you look at what an appendectomy costs in the United States, based on data from 2010, it's almost $8,000, where if you go to Germany, it would be $3,000. I don't think their appendixes are any harder to take out than our appendixes or anything like that. They tend to have the same kind of internal body organs, but for some reason it costs a lot more across the board for doing the same things in the United States that it does in other countries. Elizabeth Rosenthal, who is a New York Times reporter, has spent the last year focusing on why our costs in the United States are so much higher than other countries. She's got a great series called Paying Till It Hurts. Elizabeth Rosenthal in the New York Times, really looking at, why does our asthma medicine cost, we can, for $20, we can get 5 pills in the United States, and in England you can get 300 pills for the same amount of money. Why is that different? Why are those sort of embedded costs happening in our country? And the funny thing is that the Affordable Care Act actually doesn't deal with any of this, which I'm about to get to. These cost issues, the things that I'm throwing up here, really isn't in the Affordable Care Act at all. I'm putting this up there as sort of a challenge to you guys to let you know, hey, this is the reality of our healthcare system. And the Affordable Care Act is only tackling some of the problems and some of the challenges that we have in this country. It's going to be on you guys to tackle this stuff here, because this is going to be for the next generation of healthcare workers and healthcare reformers to deal with. Jump to the next. And here's another reason why. I mean, you might say, well, boy, the United States is a pretty rich country. Maybe that's why all of our healthcare system's more. We have more money than Greece or Sweden or France or any of those countries. But if you actually plot that, and I only pull out this regression analysis for certain audiences, and you guys are lucky enough to get it. If you plot GDP per capita versus healthcare spending per capita, accounting for the wealth of the country, we're off the chart. We're way up there. I mean, Luxembourg is off the chart as well, but I think there's 6 people who live in Luxembourg, from what I can tell. So maybe that's why they're a little bit of an outlier. But we are spending more even with the extra wealth that we have in our country. We're not on the line that the other countries are. Now, do we want to be on that line? I don't know. That's a big question. Do we want to spend less for health care? Well, will we get worse health care results? Will we not have as good of care? Those are questions that are going to have to be figured out next in terms of health reform. And the Affordable Care Act, as I mentioned, doesn't really cover that. It sort of just takes a small bite of that apple. But I hope I've convinced you in these 5 or 6 slides that we do have some significant issues to deal with in the United States. And it's really going to be something for the next, not just 3 years of what people are talking about with the Affordable Care Act, but really the next 10 to 15 years. And it's going to carry over into the careers that you're developing right now. But let's jump a little bit more micro. This is the webpage for the Massachusetts Health Connector. You might have heard that Governor Romney, back in 2006, signed into law what was known then, or known later, I guess you could say, as Romney Care. Massachusetts pioneered many of the elements that are now happening across all 50 states under Obamacare. And when Massachusetts did this in 2006, their uninsured rate was about 12%, which is pretty low compared to states like Texas, where it's 25%. Massachusetts already had a pretty good system going. But by 2013, they brought it down to 3 to 4%. I've even heard 2%. So in 7 years of health reform, they were able to bring a lot more people into coverage, even when they were already doing a pretty good job compared to other states. And they did it using the same model that the Affordable Care Act is now pushing and trying to create across the country. And now, it wasn't easy for Massachusetts. They had a lot of issues with cost. They had a lot of issues with containing the cost of healthcare. They're one of the most expensive states in the country for healthcare. They had a lot of trouble reaching out to partners like hospitals and insurance providers and getting them all to participate in this. And their website was really bad when they started out. They had, I think, about 30 people sign up in the first month of Romney Care back in Massachusetts. So certainly they have started with the same slow, glitch-prone website and a lot of hiccups along the way that we're experiencing right now in this country. Yet, over 7 years, they were able to bring several 100,000 people into insurance that weren't insured before. So when we go to conferences, when we meet people from Massachusetts, we don't sort of sit down and worship them and everything like that because, they're pretty normal policy wonks just like us. But they have been down this path before us. They are the people who can tell us, what works and what doesn't work. And they're actually tackling the problems that we're going to be tackling 5, 6, 10 years from now as well. So it's interesting that Massachusetts is an example within your research and academic studies that you do to take a look at, because they're like the Apple of states. They're thinking well outside the box and well ahead of just about everybody else. And one reason why is that they were the pioneers. They did this first. Jump to the next one. In Utah, unfortunately, our uninsured rate isn't 3 to 4%. It's 13.2. according to the latest Department of Health surveys. In Salt Lake County, it's 20%. In urban areas like Ogden, it's much higher than the state average. And you can look and you can see that it's definitely ebbed and flowed. And what we've had in our country is for many years is that your insurance, your health insurance, is tied to your job. And when people lose their job, they tend to lose their health insurance. So periods of recession, you tend to see, it's a little bit different here in Utah, but there was definitely a recession in the mid-2000s. You tend to see the number of uninsured go way, way up. And what the Affordable Care Act is trying to do is actually create a whole new option for people to get insurance that isn't linked to their job, so that we don't have this constant up and down of people being insured and uninsured that's tied to the economy. And hopefully, we'll bring that number, 13.2, down in Utah, just as Massachusetts was able to do by implementing the same reforms. Now, will it happen in all states like it happened in Massachusetts? Probably not. You know, we've got 50 experiments going on right now, and probably not all of them are going to work. But certainly in Utah, we want to make it work here, including that people who don't like the Affordable Care Act realize, hey, we're on this train, we've got to ride it, we've got to make sure that it can happen. So this is sort of where we're starting out from, 13.2% unemployment, and I'm hoping that as I do these presentations over the next couple of years, I'll be able to add some new bar charts that show that that number is coming down, that we are actually putting a dent into the number of uninsured, because the uninsured are actually a pretty significant drain on our healthcare system. Because we do provide them with care, but we do it in a pretty spotty and a pretty episodic way that isn't really the best care, as you were probably learning about how to deliver. First of all, the uninsured go to emergency rooms. You know, that is their primary care doctor. Everything from an earache to a broken arm to diabetes shock. You know, they're going to the emergency room because that's where the place they know they can't be turned away. They're going to ad hoc clinics where they take something like a basketball stadium, fill it up with 100 dentists and just do round-the-clock root canals. And that works. People get care for free that they're not getting anywhere else. But what happens when that root canal gets infected a week later? They go back to the basketball stadium, there's going to be some basketball games going on there. There's not going to be 100 dentists anymore. So they've got to go to the emergency room. So again, it's not that consistent care that you get from a primary care setting. People go to federally funded clinics, the FQHC system, which we'll talk about in a little bit. Those are clinics that do welcome everybody to come through their door, pay on a sliding scale, whether you're insured or uninsured. You guys have a great system in Ogden called the Midtown Community Health Clinics that deliver excellent care. And my wife was a family doctor at one of these clinics down in Salt Lake. So they're there as a safety net as well. They provide really good care, evidence-based medicine, but they're overwhelmed. You know, they have a lot of people using their services. And then, of course, people wait. They wait until something like a cold becomes pneumonia. They wait until diabetic shock becomes something that needs to be amputated. And that raises the cost of the care that eventually needs to be delivered to them. As you know, the earlier you treat something, the more preventative care you deliver, the cheaper it is, not only for the patient, but for the system overall. And actually treating these uninsured folks has a cost. It adds about $1,000 to the insurance premium of an average family in the United States, about $300 to the average individual. So we're paying, if you have insurance, you're paying for treating the uninsured, but you just don't realize it because it's baked into the cost of your premiums that you pay to your insurance company because they're absorbing all of these costs that aren't being reimbursed. After the Affordable Care Act, let's figure out where we might be going on this. And as I mentioned, it might work in all states. Probably not going to. It's going to work in some states. It's probably not going to work in other states. We're really in an experimental phase. And what I'd like to say is that if you're going into healthcare right now, it's kind of like you're joining NASA in 1965. Back in 1965, they knew they were going to the moon. They didn't know if they'd get there, and they certainly didn't know if they'd get those astronauts back. But that's what they were working on. And with health reform, you're trying to go to the moon. You know, the Affordable Care Act has some ambitious goals and some ambitious ideas. And if you're joining this field right now, you're joining NASA in 1965. Now, you're not wearing the skinny ties and the buzz cuts and things like that, which is good because that fashion sense is way out. But you are embarking on an interesting career in a very, very interesting time. So let's see what's going to happen. As I mentioned, the Affordable Care Act isn't going to address all those cost issues that I talked about. That's right here. You remember how an appendectomy costs 3 times as much in the United States as it does in Germany? That's this pillar of healthcare reform. Affordable Care Act kind of touches it a little bit, but it's not the main focus. What the Affordable Care Act does is it focuses on expanding coverage. That's its main goal right now. And the analogy I use is that we're trying to put everybody in the boat before we figure out how low it rides in the water and how far we can go with it. Because if you start plotting your, where you're going to go with a boat before you add everybody into it and sort of know the logistics of that, then you're probably going to run into trouble. So we're getting everybody into the boat first. We're trying to expand coverage to figure out what is our, what it can sustain. And that's really what it does. Ensuring quality and containing costs are going to come down the road, and that's actually what Massachusetts is doing, because they're ahead of everyone else right now. They're dealing with those issues, but the rest of us are just trying to expand coverage. Now, and also the other thing about the Affordable Care Act is that it has actually been in operation for a couple of years. I mean, we all know about October 1st, the horrible website, people trying to sign up, but there are things that you will probably actually experienced even, or know about, that are actually related to the Affordable Care Act. Adults under age 26 can stay on their parents' insurance plan. There's 26,000 Utahns and 7 million young adults across the country who have had that option now available to them. A lot of people we talk to in universities are very familiar with that. No more lifetime caps on insurance payments. Used to be you'd reach about a $2 million or $1 million cap, and then the insurance company could say, we're not going to pay anymore. And those parents, where their individuals would go into bankruptcy or get on Medicaid or something like that, no longer can there be a cap on insurance benefits or payouts. That's a big boon to people who have chronic diseases like kids with leukemia, who usually would hit those caps even in their teens. Men and women paying the same for coverage. That starts on January 1st. Right now, women pay more for their insurance coverage, sometimes a lot more. And that's nothing related to their health history. It's just that they're a woman. And potentially, I guess, they could become pregnant. Going forward, any insurance you buy after January 1st, men and women pay the same. Now, I can't say men and women are going to pay the same for haircuts. I've read the Affordable Care Act. There's nothing in the law about that. But at least when you go and shop for insurance after January 1st, it'll say a 27-year-old resident of Weber County will pay this. It won't say a man will pay this and a woman will pay that. It's going to be the same. And then lastly, no one can be denied or priced out of coverage for a pre-existing condition. And what does that mean? That means that maybe when you were 16, you got mono. And so when you go and you sign up for health insurance, you've got to write down that you had mono. Or maybe you've got a bad back because of a motorcycle accident. Or you have diabetes. Or even I had a friend who had some voice issues because she was a singer. And so she had to get some voice treatment. Well, when you sign up for health insurance today, and for many years in the past, you would have to list all of the sort of health issues that you had, your medications, things that were wrong with you. And then the insurance company would take a look at that and decide, well, should we provide them with insurance or not? And they could deny you or they could accept you, and then they could raise your premium based on how sick you are and how much of a risk they thought you could be. So if you have a lot of health issues, they would really jack up the price. If you were young and healthy, they would keep the price pretty low. And so people would be paying incredibly different premiums for the same kind of insurance based on their health history. For kids, right now, insurance companies can't do that anymore. Since 2010, your health history doesn't matter. And starting on January 1st, for adults, that kicks in. So for my 60-year-old nanny, when she went and applied for health insurance earlier this year, she was quoted $950 because of her health issues. When she buys insurance after January 1st, with the premium subsidy she's going to get, her monthly premium is going to be about $260. Because that health history that was causing her rates to go way up is no longer an issue. The fact that she's a woman is no longer an issue. There's a lot of things that are going to make her rates more affordable. This is one of the huge game changers with the Affordable Care Act. And one of the things we're actually reading about in the news now about whether people are trying to continue their canceled coverage versus buying new coverage that's going to start on January 1st. Because one of the big differences is all of that canceled coverage that you hear about does have exclusions based on pre-existing conditions. They can charge you more based on your health history. Any new coverage you buy after January 1st can't do that. So there's some, the fine print is very important to read if you find yourself in that situation, because this is something that's going to lower the bills for quite a few people, including my nanny. And then a lot more preventative care. Flu shots, blood pressure checks, well child checks. All of these are provided without co-pays or deductibles now, and that started about 1.5 years ago. One thing to keep in mind, though, is if you go in for preventative care and they find something, all of a sudden, you got a fever or something like that, all of a sudden that ceases to be a preventative care visit and becomes a sick visit, so you will get a copay. You will get something, you will have to pay. But if it's strictly preventative care, then you won't get that extra charge, because it's just, that's one of the innovations the Affordable Care Act has, is that preventative care actually pays dividends to the system and keeps people healthier. So these things have been going on for the past couple of years, and they are a part of the Affordable Care Act, even though a lot of people don't realize it. And even if the website is down and broken and things like that, which we all know it is, these are still going on. These are still in existence and still helping many people out right now. Yeah. Now, if we were to jump up to 30,000 feet and look down at America under the Affordable Care Act, and we happen to be looking at a PowerPoint slide, this is kind of what it would look like. What I've done is I've tried to show how the Affordable Care Act influences different types of people. And what you'll notice is that for the three categories at the top, there's not a whole lot of changes that happen to them. People who work for companies and get employer-based insurance, either big, like Wells Fargo, or small, like the group I work for, or senior citizens on Medicare, or people on Medicaid, people on TRICARE, the veterans benefits or military insurance. There's not that many changes there because the Affordable Care Act isn't focused on changing anything with them. It's really focused on the people who have struggled with getting insurance, affording insurance, or just haven't been insured at all through personal choice. So 85% of the country, they're going to have some changes. Yeah, you know, there's going to be the 10 essential health benefits that now small group insurance is going to have to cover. Senior citizens on Medicare, their prescription drug donut hole is going to go away. That's going to save them about $1,000 to $1,500 a year by the year 2020. If you work for a big company like Wells Fargo, Affordable Care Act can't touch you. You're outside of what's known as the ERISA market. And so there's nothing that happens with your insurance. You could offer insurance or not offer insurance. Well, I guess you have to offer some kind of insurance if you're over 50 employees. But there's nothing that changes with the benefits that you have to offer because you're completely outside of it. So a lot of people think the Affordable Care Act is going to come in and change everything about how they do things. But it's really this 15 to 20% down here that the real changes are happening. Everybody up at the top, and generally the people who have employer-based insurance or on government programs right now, not a whole lot of changes are happening to them. The folks that are getting their canceled policies right now in the mail, they're down here. It's actually about 5 to 10% of Americans that are that get private health insurance. And so they're actually in this category right here. It's not the folks who are up in the employer-based insurance part. And these people down at the bottom who have lost their job or looking for insurance or working for businesses that don't provide insurance, there's a couple of innovations that are going to try to help them make this insurance not only easier to buy, but more affordable and easier to keep as well. Because if they lose their job, from now on they're not going to lose their insurance if they're buying it through the new marketplace. So let's jump ahead. We'll go to a little bit of policy basics. I'm not going to spend too much time on this. The Affordable Care Act asks every state to set up 2 marketplaces in their state. Think about it. 2 senators in each state, 2 marketplaces in each state. One is going to be for individuals and families, for ordinary every people to go and buy insurance, and the other is going to be for small businesses, where a small business owner can take their employees to this marketplace to buy insurance. So every state gets these: Connecticut, California, New Jersey, and Utah. Every state's going to have these 2 marketplaces. It's really modeled after what Massachusetts did 7 or 8 years ago. You can jump to the next one. So Utah had a choice about how to approach this. It wasn't that the government said, you've got to set up your marketplaces this way. There's a bit of federalism involved. They said you can actually choose how you want to approach it. So we could have been like Texas, which said, you know, Obamacare, not really our thing. You know, we don't really want to touch it. So ironically, basically they let the federal government run everything in their state, all the marketplaces in their state. Or we could have been like California, which is, hey, we love Obamacare. We want to do it. And so the state of California is actually running the marketplaces in their state. They call it Covered California. They have advertisements with palm trees and sandy beaches and, you know, really good-looking celebrities talking all about health insurance. So they're doing their own thing right there in California. They're taking control of it. Or we could have been like Arkansas. And we could have said, you know, we're going to go half and half with the federal government. We're going to run some parts of this health reform, this Obamacare. We're going to ask you to run some parts of it. We're going to work together in a partnership or a hybrid exchange. Well, Utah looked at all 3 of these options. For a while, we thought we'd actually run the state-run exchange. That was what Governor Herbert wanted to do. And then we kind of veered towards the federal exchange, and then we even kind of dated a little bit with the partnership exchange. But being Utah, what we decided to do was we said, you know, these are 3 options, but they don't really work for us. We're going to make a 4th option. We're going to walk right through it. And that's what Utah did, is we created what's known as the split model, where the federal government is going to run the individuals and families marketplace, healthcare.gov, and the state is going to continue running the small business marketplace in the state. So it was unique. No other state had proposed this. Governor Herbert negotiated with the federal government and got it approved last May. And this is what we're operating in right now. We're sort of the 4th way to approach the Affordable Care Act. We heard Mississippi is interested in following us, so this could become a new option that other states pursue. Now in Utah, we've already had a small business marketplace going back to about 2010, because as Carla mentioned, Utah had sort of gotten a little bit onto the health reform bandwagon earlier under Governor Huntsman and Governor Levitt. And so we had a small business marketplace that predated Obamacare. And that's one reason why Utah did this model, is because they wanted to preserve that. They wanted to preserve what's known as Avenue H. And I actually, just driving up here, saw some billboards for Avenue H along I-15. So they're doing some advertising now, trying to bring people and small business owners into the marketplace to get their insurance there. But here's how it works. If you're an average Joe, and I used to be a freelance writer, so I used to buy my own insurance in the private market, I can't go to Avenue H. I can only go to Avenue H if I have between 2 and 50 employees in my business right now. If I'm an average Joe, I go to the individual and families marketplace. That's where I go and get my insurance. If I work for a company that doesn't provide insurance, or I'm self-employed, or I'm unemployed and uninsured, I go to the individuals and families marketplace. The only way you can go to Avenue H is if you work for a small business, under 50 employees, and your boss takes you there. And even if they take you there, you can still bail out and go to the individuals and families marketplace if you decide. So based on those constraints, we think a couple 100,000 people in Utah are going to get their insurance on the individuals and families marketplace, and a couple thousand, maybe 10,000 at the high end, will get their insurance on Avenue H. It kind of depends on how popular, how much advertising they do, and things like that. But at the Utah Health Policy Project, we tend to focus on the individuals and families marketplace. That's who we are talking about, because the state is really doing its own promotion around Avenue H. Jump to the next one. If we were to look at a national map about how this all works out, the dark states are the states that are running their own state exchanges, like California or Oregon. Up in Minnesota, they're using ads with Paul Bunyan, falling off roofs and falling into frozen lakes and things like that to kind of get the point across that health insurance is a good idea. So these dark blue states are the ones that are doing it themselves. The really light blue states are the ones letting the federal government run everything there. The middle blue states are those hybrid exchanges like Arkansas, where they're kind of going half and half. And then Utah, which is probably the only national map where we'll be purple on for quite a long time, is doing its own thing. We're doing this split model where the feds are running half of it and the state is running the other half. When they set up the Affordable Care Act back in 2010, I think they thought there'd be a lot more dark blue states on this map. They thought more states would want to take control and do it themselves. And so they were very surprised when it worked out that you have 26 federal exchanges, or 26 states where the feds are running everything, which is one reason why healthcare.gov was such a disaster when that website launched. Because it's not just one website. You go to healthcare.gov and then you immediately choose what state you're in. So it's not just one website, it's 26 websites, and in fact it's 42 websites because there's a small business side of that as well. So they really had to set up quite a few dynamic websites for many more states than I think they intended to. Not to give them any excuses for really bombing that rollout, but they did have a lot more work than they intended to do. And here in Utah, we are using healthcare.gov. Because this is the website where folks are going through and finding their insurance. This is a screen capture just from a couple days ago. You guys remember the young woman who used to be on the website? You probably read stories about her. She just actually did an interview on ABC News because she was really upset about the bullying she was getting. Well, now they've changed it. They don't have that young woman there. They just have ways to help get you insured. But if you want insurance in Utah, and you want to go through the marketplace for individuals and families, you go to healthcare.gov. That is the only portal that you can access that for. And it's kind of important because if you want to see if you qualify for subsidies to make your insurance more affordable, this is the only place you can go. If you go to the private market, call up an insurance company and get insurance that way, you can definitely get insurance. But you could be leaving a couple $100s a month on the table by doing that if you were to qualify for subsidies. So it's a really good idea to go through healthcare.gov to find out if you're going to get that help every month to pay for insurance, because there's a lot you can do with an extra $300 a month. It could definitely help. So the website's healthcare.gov. It's also available in Spanish, and there's the toll-free number 1-800-318-2596. Now we've heard the website is bad, and it certainly was bad. We can jump to the next one, but it is getting better. These are some screenshots from earlier this week where we were enrolling. Actually was fake enrolling myself. You can go in there, you can use it. Some of the tricks that we've used, if you've had trouble logging in, delete your internet cache or your internet cookies, or just download a new browser. If you're using Internet Explorer, download Chrome or download a fresh version of Firefox and just use that, because there's a lot of bad logins previously which have been clogging up the pipes. They say the website's going to be fixed by the end of this month. Unfortunately, I don't think that's going to be true. I think it's going to be sometime in early December, mid-December when it's going to be fixed, which really runs really close to that December 15th deadline of when you need to sign up for insurance that starts January 1st. So that's really causing some anxiety for advocates and organizers like myself that we want people to have that insurance that starts January 1st, and it's going to be pretty tight. The good news is it takes about 45 minutes to sign up. So it's not an extremely lengthy process because, again, you don't need to fill out your health history anymore. It's a totally different kind of insurance application process. Jump to the next. Now, on the Utah marketplace, we've actually got a pretty good deal going on. We have 6 major insurers offering insurance, offering 96 plans. And these are the big insurers. These are the billboards you see driving up and down I-15 or 89 that are offering the insurance. I mean, Select Health and Altius sort of are the 2 bigger plans, and we got a lot of other ones as well. There's also a bunch of dental plans. If you're in a smaller state like Wyoming or Georgia or Mississippi or Alabama, they actually have many fewer insurers and many fewer plans, which has really reduced the amount of competition they have. So Utah's pretty lucky that we've got this robust of a marketplace going for us, because what it means is that more competition is bringing down the prices, and we've got some of the lowest prices, lowest premium prices in the country. Yep. So what is the marketplace going to be like? Well, before we get into the guts, let me just step back anecdotally. Shopping for insurance on the Utah marketplace is going to be a lot like buying breakfast cereal. And you might be like, whoa, how's that possible? How could it be that shopping for something as complicated as insurance can be as easy as going and buying your Fruit Loops, at your local supermarket? And here's why. Supermarkets are smart. They put all the breakfast cereals in one aisle. So that when you go to the supermarket and you want your breakfast cereals, you go to aisle 3 and you have all the choices lined up in front of you. And you can take the boxes, hold them next to each other, look at the nutrition facts. You've got a 2-year-old like me, they shake it to see if there's a toy inside. All of your choices are right there. And not only that, but the prices are right there on the boxes as well. So you know exactly what you're going to be paying when you go and you check out from the supermarket. The insurance market up until now has been very different. You basically have to go to one insurance website, fill out a long health history survey, and then get a quote. And that quote would be based on how sick you were or your age and smoking history and things like that. If you wanted another quote, you'd have to go to a completely different company and fill out an entirely new survey and get a different quote that way, and then go to another one and get a whole different quote. And that could take hours and hours to actually build the same competitive advantage that you gain by going to the supermarket cereal aisle, where you have all of the prices and all the products right in front of you with no gimmicks, and it's all pretty transparent. What the marketplace does is it takes insurance plans and insurance providers and puts them in one spot, in one cereal aisle, so that the numbers that you're seeing and the information you're seeing about these insurance policies are all consistent and they're all in front of you, so that you can hold up one insurance policy, see the deductible, see the premium, see the provider network, see what it covers, and then hold up another right next to it and see those exact same details, just like you're comparing boxes of cereal. And then imagine this. If you were going to a cereal aisle and you had a box of Cheerios and it said $2 on the box, and then you bring it to the checkout line and they scan it and it says, oh, it's not $2, it's $10. Well, that would be kind of a shock, wouldn't it? And that's one of the challenges with the private insurance market right now, is there's a $2 prices for everybody, but once you fill out that health survey, you could be paying $10 depending on what kind of health status you have. So there wasn't that same transparency about knowing exactly what you were going to pay and everyone paying sort of a similar price for it. So what the marketplace does is it has the prices right there as well, and there's no shock that you find out when you go to the checkout line to actually purchase it. The price you see is the price you're going to pay, and if anything, it's going to be lower based on the premium subsidies that you could get. So that's, I'm sorry, can you go back once more? So that's why the supermarket checkout line is very similar. A supermarket cereal line or aisle is very similar to what shopping for insurance is like. But there is one caveat. It's not going to be as simple as going and buying cereal, and that's because there's going to be a little bit of TurboTax involved in this. Because no longer are you going to be filling out a long health survey, but you are going to be asked questions about your income. And the questions are going to be about how much you think you're going to make the next year, and they ask you that because they want to see if you're going to qualify for premium subsidies, which I'll get into pretty quickly next. The new insurance is also going to have these 10 essential health benefits in it. Any new insurance that's sold in the private market or in the marketplace after January 1st is going to have these things in it. And it's interesting, if you go and look at health insurance websites right now, most of the plans you can buy that take effect on December 1st don't have maternity care. They don't have certain benefits, that prescription drug care, or maybe they'll cover the first $200 of an ambulance ride and then you're on the hook for the rest. There's a lot of fine print that it's important to read when you buy insurance today in the private market. Going forward after January 1st, it's going to have these 10 essential health benefits. It's going to cover maternity care. It's going to cover things that you really want it to cover. And there will be some options for people who just want catastrophic care, but for people who want, robust insurance, it's all going to be there, including adult vision and dental, which can be purchased as a rider. And when you go on the marketplace, this is what you're going to see. Well, not exactly. It's actually going to have plan names. But you're going to see insurance plans divided by different color codes, by different metal tiers, sort of getting us ready for the Olympics coming up in February. There's going to be bronze, silver, gold, and platinum insurance plans. Now, all those plans are going to have the same benefits. It's not like the bronze plan's not going to have maternity care and the gold plan is going to have maternity care. No, they've all got those 10 essential health benefits for the most part. There could be some slight variations within them. But how they differ is in how you pay for the insurance. A bronze plan, as you can see, is going to have low premiums but higher cost sharing. That means your deductible, your co-pays are going to be much higher, maybe $20 for prescription drug, $50 to see a specialist. A gold plan, on the other hand, is going to have higher premiums but lower cost sharing. So you're going to pay more month to month, but when you go see a specialist, it's going to be $10. When you get a prescription drug filled, it's going to be $3. So there's different ways that you pay for your insurance, and what it does is it gives you more of a selection. So that if you use a lot of health care, then a gold or a platinum plan probably makes more sense because you're going to save more money overall, even though you're paying higher premiums. If you don't use a lot of health care, if you're young and healthy, then a bronze plan makes a lot of sense because you got low premiums, and if you need an occasional doctor's visit, yeah, you're going to pay more, but you're going to save more overall because you're not paying as often. Catastrophic plans, which I'll mention in a little bit, are kind of outside of that, and they're primarily designed for people under age 30. And as well as for low-income people as well. So they're a little bit different. They don't have all those 10 essential health benefits. In fact, if we jump to the next slide, I think I've got the description. I call it the Utah Snowboarder Plan, which is actually, you guys got some snow going on, it looks like today. So it's something to keep in mind. If you are going 25 miles an hour and you hit a tree, you're probably going to get a $20,000 hospital bill, depending on how many casts and tubes they put into you. The catastrophic coverage is going to be really inexpensive for young people under age 30, but it's going to cap what you pay for any kind of hospital bill at $6,300. So if you wind up with a $20,000 or $30,000 hospital bill, it's like buying a nice Lexus. All you're going to have to do is buy an old Subaru when you pay your bill, because you're going to be paying up to $6,300, and then the insurance is going to cover the rest. So it's a really good option for people who are like, insurance isn't for me, but then go and like to jump off cliffs, ride motorcycles, or snowboard, down mountains, because it's a good, inexpensive, but financially secure insurance product that's out there for people under age 30. So I just bring that up when I'm within these kind of younger audiences, because it's certainly something not a lot of people know is going to be an option. You don't get premium subsidies if you buy it, but the premiums are actually pretty low, $60 a month and things like that. So it definitely can be worked into a lot of budgets. Jump to the next, thanks. If we were to look in Salt Lake County, this is actually what and I'm sorry, this is Weber County. I put the Weber ones in. These are the cheapest plans by age in Weber County. If you go into the insurance marketplace right now and you were to look by age about what is the cheapest plan that you could buy, these are different providers are providing these different plans. This is what they would cost. So if you're a 30-year-old in Weber County and you want to buy a silver plan, the cheapest plan is about $193 a month for a 30-year-old in Weber County. For a bronze plan for a 30-year-old, looks like it's about $150 or so. You can see this line right here. Now there are insurance plans can't charge you more based on your health history anymore if you buy this new insurance, but there are 3 things that they can charge you a different price for. And if you notice here, this is Weber County. If we were to buy insurance in Salt Lake County, if you were a Salt Lake County resident, it would actually be a different price, because there's 6 regions across the state that insurance companies have varied the prices by. Salt Lake County is actually the cheapest, Weber County is the second cheapest, then Utah County, and then there's other regions around the state. Now why can they do that? Because insurance companies have decided that delivering health care in different parts of the state costs a different amount of money. So they're able to adjust the prices based on the different costs that they incur. Another way they can charge you more is whether or not you use tobacco. If you use tobacco at any point in the last 12 months, you have to answer that you did use tobacco, and they can charge you up to 50% more for a portion of the premium for that. And the third is actually very evident. It's age. The older you are, the more you're paying for a plan. Although it's a little bit different. It used to be that insurers could charge you 6 times more based on your age, then an older person versus a younger person. After January 1st, that drops down to 3 to 1. So the age band is going to be shrunk, which is one reason why my nanny, who's 60, is going to be paying less when she goes and buys insurance that starts after January 1st. So there's 90 plans in Weber County offered by those 5 health insurers you see right there, and they range from the catastrophic to the gold. I don't think there's any platinum plans being offered. So these are the cheapest prices. If we jump to the next slide, we'll actually see the most expensive prices. So that 30-year-old buying a bronze plan, the most expensive bronze plan is about $220 or $230 a month. I think it was $150 was the cheapest, $230 is the most expensive. All the other ones are going to be somewhere in between those. So this is a little bit of a bookend of what plans are going to cost. But as I mentioned, this is a sticker price. You're not going to pay more than this, but many people are actually going to end up paying less, and here's how. We expect almost 300,000 Utahns to qualify for premium subsidies if they shop for insurance through the marketplace. It's actually about a tenth of 10% of the population here in the state. It's actually quite a few folks up in Weber and Cache counties as well. It tends to be where younger people are, and younger people tend to have lower incomes, and they're the ones who end up qualifying for these subsidies because, you can jump to the next. How much you make determines whether or not you're going to get a subsidy and how big that subsidy is. If you're on this chart, you can see yourself on this chart, or your family on this chart, then you qualify for a subsidy. Because for people who make between 100% and 400% of the federal poverty level, which for a single person is between about $11,500 and $46,000 a year. Now the subsidies are sliding scale. So someone who's right here is going to get a bigger subsidy than someone who's over here, based on your income. And so you could be up to a family of 4 making $94,000 a year and still get a little bit of help every month to pay for your insurance premium. And the median family income in Utah is about $57,000, right about here. So there's a lot of folks who are going to qualify for these subsidies. Now, if you work for Wells Fargo and get insurance from Wells Fargo, can you qualify for a subsidy on the marketplace? You can't. Because if you have employer-based insurance, the idea is that you stay with that employer-based insurance. It's only really for folks who are uninsured, self-insured, buying their insurance in the private market, or have just never been able to get insurance because of their pre-existing conditions or how much it costs. So these are the folks who can actually take advantage of the subsidies. Now you work for Wells Fargo and you lose your job. Then you can go to the marketplace and buy insurance. You don't need to have a job to be able to go and access this kind of insurance. Let's take a look at some examples. Here's looks like someone from Ogden down in Moab. Henry earns $18,000 a year. There's a new chart that says if you earn $18,000 a year and you're a single person, you're expected to pay about 4.31% of your income for your insurance, which for Henry would be about $775. Now he buys a silver plan that costs $2,300 a year. So what that means is that his premium is going to be $193 here in Weber County. He's going to pay $65 a month, and he's going to get a subsidy of $128 a month, which means every month Henry's going to write a check for $65 to his private insurance company. Every month the federal government, the Treasury Department, is going to write a check for $128. The two checks are going to meet at the private insurance company and make up the full premium. That's how it's going to work. All of a sudden, Henry, who probably could think of a lot of other things to spend $193 every month on, is going to be insured for $65 a month, which is probably cheaper than his cell phone bill, to be honest. So it probably makes his mom pretty happy too. But that's just one example. Let's look at another. The Shumways, they live up here in Ogden. These are fake people, by the way, not real. They're buying insurance for $3 because they got a kid on the way. They make $44,000 a year. The premium would normally cost them $460 a month. But they're going to pay $263, if I'm doing this right, yeah. And they're going to get a subsidy of $193. So instead of paying, almost $460 or almost $500 a month, they're going to be able to be insured, have the delivery covered, prenatal care, all that stuff covered for $250, $260 a month. So all of a sudden insurance is a little bit more within reach of this family who obviously, whatever job they have or jobs they have, they're not getting it through their employer. And then lastly, one more group. This is a family we encounter quite a bit, the people waiting for Medicare, folks like my nanny. So they make $42,000 a year. Their premiums would be a lot more. Look, $10,000 a year, almost $900 a month. One reason why is they're much older. Insurance companies can charge them more because they're older. They can't charge them more because of their health history anymore, but they can still charge them more because of their age. But they're just going to pay $300 a month, and they're going to get a premium of almost $600 a month to make that insurance more affordable. Now, why is that important? Well, I know firsthand from my nanny is that she's going to qualify for Medicaid in 5 years. She's right at this age right here. But if she's uninsured for the couple of years before she gets on Medicare, I'm sorry, not Medicaid, Medicare for the older folks, she's going to be in a lot worse shape when she shows up on Medicare when she turns 65. If she's insured leading up to those years that she gets on Medicare, she's going to be healthier and she's not going to incur those huge costs on our public healthcare system through Medicare. So that's why insuring these folks makes a lot of sense, because all of a sudden they're going to be getting their diabetes taken care of, they're going to be getting their high blood pressure taken care of, get those medicines, get that preventative care, so they're going to be healthier when they go on Medicare. And Medicare is actually the biggest cost driver of healthcare in the United States. So it's huge if you look at its influence on our budget. So getting them healthy is really important for the rest of our economy as well. So those are 3 examples. If you would actually like to run your own examples on yourself, you can do it on this website, kff.org, Kaiser Family Foundation. They have this website where you actually put in your zip code. It knows it down to the zip code in terms of what you'd be paying for health insurance and then what you'd be getting as a subsidy. Now, it doesn't tell you all the plans. There's a website called Health Sherpa that does that. But this one at least will tell you what, if you bought the middle of the road silver policy, kind of the bullseye policy, what you'd be paying and what your subsidy would be, and that's what I used to create those examples we just saw. So kff.org, the premium subsidy calculator on that website. And it works. It's one of the websites that actually works. So now, where is all that money coming from? You saw that family, the 60 and 62-year-old, they're getting $600, $700 a month in a premium subsidy. Where's that money coming from? I often joke that we're growing it out in western Utah using rainbows and unicorns, but you guys are too smart. You're not going to believe me if I say that. So this is where it comes from. It comes from cuts, and it comes from taxes. These are the cuts. There's cuts in Medicare Advantage plans, which are private Medicare plans. They pay up to 17% more than traditional Medicare. The government said we don't want to pay that extra 17%, so they're ratcheting it down over the next couple of years to be on par with traditional Medicare. About 30 to 40% of Americans have these private Medicare plans that they're using. So that will affect not their benefits, but it will affect how much their doctors and hospitals are getting reimbursed for the care they're providing. So something that influences people on the provider side of things. Uncompensated care for hospitals is being cut. Hospitals treat a lot of people who are uninsured. Those people can't pay their bills. The hospitals write off their debt. The hospitals are reimbursed by the federal government through what's known as DSH payments, or disproportionate share hospital payments. Well, if more people are getting insured, the federal government's like, well, why do we have to pay these hospitals all this money if more people are actually going to be able to pay their bills from now on? So the hospitals are going to lose about $56 billion over the next 10 years that normally went to pay for this uncompensated care. It's kind of a leveling out. The idea of more people have insurance, hospitals don't have to provide as much charity care, so the federal government can stop subsidizing that through the DSH payments. Medicare and Medicaid payment rates. Many of these have actually been pre-negotiated between doctors and hospitals about what they pay for a colonoscopy or what they pay for specific procedures. And that's actually a huge amount of cuts. Remember I said Medicare is one of the biggest cost drivers in our economy? If you make something cost $5 cheaper in Medicare, you save, millions of dollars within a couple of weeks because of the sheer volume and the sheer impact that it has. So a lot of the cuts are happening in reimbursement rates for hospitals and doctors through Medicare and Medicaid. A lot of them have already been pre-negotiated and the doctors and hospitals agreed, but that is, of course, almost half of the, more than half of the cuts that are happening over the next 10 years. So again, a big hit on the provider side. Not that patients are going to experience it, but it does hit the provider and hospital side. And then there's taxes. The way I like to say it is we all hope we get hit with the Obamacare taxes. A lot of people shake their heads and they're like, what? It's because the taxes that personally affect individuals are for people who make more than $200,000 as an individual or $250,000 as a couple. And those are taxes on your capital gains. So you sell a stock, you sell a bond, you make money on that, and you earn over those income limits, you're going to get an extra 3.8% tax on that. So definitely folks who are in the higher income ranges, I think it's about 3% of Utah families fall into that category. Also, if you sell a house and make more than $500,000 profit, there's going to be an extra 3.8% tax on any dollar amount over your $500K profit. Medical devices tax, really big here in Utah. We have a lot of medical device makers in the state, especially down in Utah County. So they're getting a big tax on their net. And so there's a lot of companies that are upset about that. One thing I would say is if you read Elizabeth Rosenthal's New York Times story about a guy who flew to Belgium to get a knee replacement, his knee replacement would have cost, I think, $100,000 in Colorado, and it cost him $13,000 in Belgium, even though the knee that he got, the titanium knee, came off the same loading dock, the same company in Warsaw, Indiana. So for some reason, the knee in Colorado cost $26,000 to actually purchase and pull out of the wrapper, and it cost $3,000 to do that in Belgium. So medical device makers have certainly been making a lot of money off their devices, and that's one reason why I think that they were targeted with this very specific tax on them. The penalties for individuals and employers are also a point of this. I guess you could call that a tax on individuals as well, especially the one for people who decide not to have insurance. Cadillac health plans. Those are plans that have very generous benefits, no copays, no deductibles, often found in unions, auto workers unions, longshoremen, people like that, and executives have those as well. What that does is it causes people to use more health care than they need, which tends to cause more waste in the system. People have copays and deductibles because it makes you think hard about whether or not you actually need to go see the doctor. And imagine if you didn't have that, you would probably go a lot more if you didn't have to put some skin in the game. And then cost savings as well, the idea of the preventative care, getting more people into coverage. If you catch something earlier, usually costs a lot less money to treat it than if you wait till it gets really bad. So that's where the $200 billion of cost savings come from. These are the penalties. I want to jump through these quickly. You might know some people who want to pay the penalty, who don't want to get this new insurance. My brother-in-law is among them. He lives in California. He and his family are not going to get insurance. They're going to pay the penalty. They actually don't use electricity or cars as well, so they're a little bit unusual in the way they approach things. They decide that health insurance is not something that they want to be a part of. So they will pay $95 per adult or $47.50 per child, up to a max of $285, or 1% of their family income for 2014. And then those penalties ratchet up until after 2016, they're pegged to inflation. And when I talk to my brother-in-law, and it's funny because my wife's a doctor, and her brother is this guy who doesn't believe in insurance, they have some big discussions. And they have money saved up to pay for healthcare bills, but they don't have $100,000 saved up. If they get hit with a $100,000 hospital bill, they're going to walk away from it, despite their best intentions. They're not going to be able to pay that. They have 100,000 cucumbers in a barn. They don't have $100,000 to pay any kind of hospital bill. So what the penalty does is it gets them to have some skin in the game, so that they have to walk away from a bill. They're not leaving that bill for the rest of us who are paying insurance premiums to pay for them. So that's the way the penalties are worked. That's how they're designed to, they don't give you insurance, but they do support a system that will pay your bill if you can't pay it. So those are the penalties real quickly. And at this point, I wanted to pass this around. We do this Health Matters newsletter that comes out actually next week. We do it once a month. It covers healthcare topics. It's focused on Utah. We do it every week during the legislative session and every month for the rest of the year. We have a lot of issues coming up as we're preparing for the legislative session. But we talk about the same issues that I'm bringing up here. We bring you the updates on enrollment numbers. We talk about legislation that affects providers and hospitals. We talk about Medicaid expansion. We interview people who are sort of the movers and shakers in the healthcare field around the state. I used to be a magazine editor, as Carla mentioned, and so we really try to make it something that isn't going to put you to sleep. We try to make it something that is going to be read by a wide variety of audiences, including a lot of providers and doctors. So if you wouldn't mind, if I could, we'll just throw it. There we go. Thanks. Pass it around. If you're interested, put your name and your email. We'll add you to the list. You'll get your first one at 6 a.m. on Tuesday morning. I'm sure you'll be waking up early just to read it. But Health Matters is the newsletter that we put out at UHPP. Thanks. So a little bit of information about health professionals, people in this field. I wanted to deliver some information. We had to get through the boring stuff first. I apologize. But let's jump into it. So first of all, we're kind of lucky to live in Utah. Utah has the lowest cost health care in the country. This was a Wall Street Journal article that came out earlier this year. If you look at Utah, we're, if not at the top, we're near the top of all of the key drivers of healthcare efficiencies. Now that's good in some way. That's actually really good for insurance companies because that means they don't have to pay as much money. They can run a much more efficient operation. It's actually not as good for providers and hospitals because they don't get reimbursed as well as places like New Jersey or Massachusetts where the costs are all much higher. So, I mean, and the other way you can think about it is it's actually good for providers because they're dealing with a much healthier population. The obesity rates, diabetes rates, smoking rates, things like that in Utah are much lower than in other states. And so as a provider or someone working in the healthcare field, you're not dealing with as many issues as you could be if you lived in, Florida or New Jersey or something like that. So Utah is a special state. Whenever we go to conferences, they always put up charts, and Utah's always floating off in the corner, not with all the other states, because we have a lot of interesting dynamics at play within not only our economic side, but in sort of our demographic side as well. So you live in a special state. I guess that's what I want to get across. If you decide to work or practice healthcare in Utah, there's some good and bad things that come across with that. Now, do we have enough providers in Utah? And that's one of the big questions that we've got. Now, if we look at it nationally, we do have a shortage in primary care physicians. This was a Health Affairs article that came out just this month that I have referenced there at the bottom. We have a shortage in primary care physicians nationally, and we certainly have that here in Utah. Primary care, as you know, are family doctors, internal medicine, pediatrician, and emergency room as well. So those kind of physicians we definitely have a shortage in. But the good news is we have a surplus nationally of nurse practitioners and physician's assistants. And so what I think we're going to see going forward is that there's going to be a new leveling of the provider networks. Despite the strong opposition from the American Medical Association and other doctors groups, mid-levels, PAs and nurse practitioners are going to get more involved in delivering patient care. And I think that's because of these dynamics that we're seeing here and because of all the new people coming into health insurance. They're going to be going and wanting a primary care physician to be able to treat their symptoms and make them better. So there's going to be some kicking and fighting, especially by doctors who don't want to give up some of the power that they have. And my wife's a doctor, so I see how that works. But we're going to see a definite broader field of people providing health care in our country, and specifically on the mid-level side of things. So that's how it looks nationally if you look at by year 2025. I think the next slide, actually, could you skip forward one more? This is how it looks in Utah. Utah does have a shortage of primary care physicians like many other states do. And part of it is that we have a very fast-growing population, and we only produce, I think it's 60 to 100 new doctors a year from some of the different facilities we have here. So, we certainly are low in terms of these numbers, but this is the other thing. What we really have a shortage of in Utah is pediatricians, because we have the youngest population in the state. We actually are pretty good on internal med and pretty good, especially on geriatricians and people like that. What we need are more pediatricians because we have a lot of kids. We need more dentists. Actually, we have quite a few dentists, I should say. More pediatric dentists. We definitely have a population bulge at the lower age ranges, and so that's where our primary care doctor and provider network is facing the biggest stress. So these are sort of broad numbers from the Kaiser Family Foundation. If you actually go to people in Utah, they say, yeah, we need more peds docs. We need more people focused on kids. If you could jump back one, thanks. And this is one reason why we don't have enough primary care doctors, is that very few people go into the primary care fields. Specialty has a really strong draw because of sometimes the work hours, but most often the salary. If you look at what a radiologist makes, $315,000 a year versus what the average starting salary for a family doctor, $158,000. Now both of those sound pretty good for me. I work in a nonprofit setting, so that's that's a pretty good salary. But when you're facing loans and you're facing the peer pressure of what you go into as a healthcare field, this number and these other numbers are pretty strong draws. But the one thing I challenge you guys is that if you're thinking about, you're in medical school, you're in the medical field, and thinking about residency, if you want to really make a difference, then going into primary care is where it's going to be at. That's where the focus of all the money, all the research, all the investment is going to be in primary care. And I think we're going to also see these salaries coming down because there's not going to be as much investment and as much interest in some of the specialties as there has been. There's going to be a change in the way the healthcare career structure works because we can even see it in Utah right now. Federal government's putting millions of dollars into creating more community health centers across the state. Who are they hiring? They're hiring PAs, nurse practitioners, pediatricians, and family doctors. That's who they're hiring. So that's where the emphasis is going to be. There's still going to be the need, but I think it's not going to be as sort of lucrative as it has been. So thanks. I think we can go forward right here. And these are the federally qualified health centers that I mentioned. In Utah, I forget how many we have. I think we have about 16. But we've got 6 new ones coming in over the next 6 months. And these are centers that serve the underserved. They offer a sliding scale fee system, which means depending on how much you make is how much you pay. They accept people who are documented and undocumented. Your immigration status doesn't matter. And they provide comprehensive care. They do deliveries, maternity care, kids, senior care. They do it all. And they have a pretty good connection to the best evidence-based medicine. I'm a little biased because my wife used to be provider here at the one in Taylorsville. But they're a pretty good healthcare system. So if you're interested in going into primary care, but you're worried about your student loans, and you're worried about how am I going to pay off all this debt that I've accrued, if you work for an FQHC, you can actually get some pretty good loan, what is it called, where they just, stop worrying about your loans. They pay it off for you. Forgiveness, thanks. Loan forgiveness. It depends on where you practice, but you can get loan forgiveness if you go work for an FQHC, depending on different areas of Utah that you're in. There's some places that forgive it all, others forgive 75, 50, 25%, depending on the area. But definitely check out the FQHCs. They're something unique that not a lot of people know about, and they're a very interesting alternative to private practice. I know a lot of physicians who have gone to private practice, worked in an FQHC, gone back to private practice, and then can't wait to get back to the FQHC because they've seen it on both sides and they realize that this is the place that they want to deliver medicine. The other thing is your malpractice is taken care of if you work there. You don't have to pay any malpractice because the government assumes that liability for you. Jump ahead. Now, as someone who works in the healthcare field, no matter what you are, I mean, we have doctors and nurses listed up here, but you really can be anywhere in the healthcare field, and you have people coming up to you and asking you questions. What is Obamacare? When do I sign up? I've got this thing on my back. Can you take a look at it? You guys probably get all those kinds of questions. And that's because doctors and nurses and people in the healthcare field are some of the most respected people in our community, much more so than politicians, lawyers, or anybody else, and especially for information about healthcare reform. Which is kind of ironic because in medical school or any kind of healthcare field, you're probably not learning about what's in Obamacare. You're learning about, body systems and pedagogy and things like that. But you still get those questions. And so that's one reason why I'm glad to be here to talk to you, because people do trust you if you're in the healthcare field. The challenge is people trust you. If you go to the next slide, please. Unfortunately, they get most of their information from somewhere else. They get it from the news media. If you look at the bottom there, 81% of the information about healthcare reform comes from the news media. Not as much comes from the people that they trust the most. So that's a disparity that we've got that we really need to overcome. And so the way I want to finish this section, I think it's on the next slide, is just give you a quick little primer about the 5 things I'd appreciate if you could mention to folks when they ask you about healthcare reform. First of all, letting them know about healthcare.gov. It still is the preferred portal here in Utah to go and shop for insurance and get your questions answered. So healthcare.gov is not doing well, certainly at the beginning, but it is getting better, and it is going to get to be the place that you're going to go and buy that healthcare insurance. Second, for people who have had problems with buying health insurance, they've struggled with it, they've been denied, they've gotten quotes for premiums that are just astronomical, they can never pay. There's a new system in town. Being sick doesn't matter anymore in terms of what you're paying for your insurance. So it's worth going back and taking a second look and seeing if this is something that can now work for you. The third is, this is probably the most overlooked, is that Obamacare insurance is private insurance. Most people would think it's some sort of government system where, President Obama comes and, checks on you or something like that. No, it's private insurance. It's the same private insurance companies that you see the billboards for driving up and down I-15. And there's 5 of them here in Weber County offering 90 plans on the marketplace. So reminding people that Obamacare is private insurance, and that's what you're buying, and that's the kind of care that you're going to get. Fourth is that there's subsidies out there, as we saw from those 3 families, those 3 examples, that are going to make insurance more affordable. If you struggled with paying for it or never could work it into your budget, the subsidies are there for people who earn between 100 and 400% of poverty, which is a pretty big spectrum of our country here, to make those monthly premiums definitely fit within budget. So again, something to look at. If you don't buy your insurance through the marketplace, you're also leaving that money on the table as well, because it's there and it's available, but if you don't go through the marketplace, you can't access those subsidies. And fifth, and actually I haven't gotten to this, it's in the next section, there are people trained to sign you up, navigators and enrollment specialists that are there that, as someone who works in the healthcare field, you want to make people better. You want to make, help them in whichever way they came to you to get help for. But you're not there to train them and tell them how to sign up for insurance. There are people in our state who are trained to do that. And if you can direct them to those folks, then they can get the help they need, and it's actually more efficient for you. So we can skip forward actually to this section, and let's just skip forward 1 or 2 more slides. This is actually one back there. This is the website that we really want you to send people to, or even go to yourself. TakeCareUtah.org. We set it up in the state for about $1,000. Took us about 3 days to put it together. And what it does is it helps you find those enrollment assisters, those navigators or certified application counselors who are closest to you. It's like finding your nearest Home Depot. You type in your zip code, and then it puts out a Google map and the address and the information for these trained people who can help you. And these people have gone through federal training. They've got the same background check you need for a concealed carry permit here in Utah. They passed ethics laws, and they actually carry insurance as well. So if they make mistakes, there's insurance that they carry that can reimburse you if it's something that they do. So it's a pretty serious training procedure. These are not Joe Schmoes off the street. We're going to sit down there and sign you up for insurance. These are trained navigators and certified application counselors that you can access through this website, verified and certified by the state of Utah. So this is a good website to keep in terms of referring people. There's another one which is dialing 211, which is a statewide information number set up by United Way. United Way 211. So if you don't have internet access, you can call 211 on your phone and be connected to the same resources you can get at TakeCareUtah.org. They even have navigators on the phone to answer questions there as well. The third one, let me jump ahead, is the community health systems themselves. Here in Weber County, we have the Midtown Community Health Clinics, and they're a really impressive set of community health clinics in northern Utah. And you can find them by going to ouch.org, which I think is the best acronym in any healthcare nonprofit I found. They're the umbrella organization for all the community health clinics. And not only do they have people there who can make you better and deliver your baby and stuff like that, but they have certified application counselors on staff to sign people up for insurance as well at the same time. One more that I want to mention are insurance brokers. We don't want to leave the broker community out of this. They are interested in this business as well. They've been trained and certified, many of them, to provide the same kind of insurance as well. So if you already have a trusted relationship with a broker, you can see them and they can sign you up for the same coverage, and they're not compensated. You don't have to pay them any money or anything like that. This is what they do, signing people up for insurance. You can find your agents at utah.gov/agent search as well. And then one more, I think. Well, actually, no, that's it. Next is the Medicaid expansion discussion, but I wanted to check on time because I know we might have some questions here that I might want to address as well. Should we go directly to questions, Adam?
You're good. Either way.
What time is it right now? 2:53. Let's do some questions before we jump into Medicaid expansion, because I realize I've spoken for a long time and maybe you guys had some questions. Got one right there. Yep.
I have two questions actually. One is
sure.
It can't be priced out. Is there caps on policies? So when you say an individual can't be priced out, is it regulated cap?
Mm-hmm.
Okay.
Yeah, let me answer that first one. So priced out, what that refers to is if you have diabetes or you have some sort of a health condition, it used to be that an insurance company could say, yes, we'll give you insurance, but it's going to cost you $1,200 a month. And so that's really what's being priced out. It's an offer, but it's not an offer that most people can pay. So in terms of the new marketplace, the price of the insurance you pay isn't going to be adjusted based on your health history, but it will be by your smoking, geography, or your age. And so it is conceivable, though, that if you're 64 years old and you smoke and you live in one of the high-cost geographies, you could be paying quite a bit for that insurance. It could be $700, $800 a month. And if you don't fall into the premium subsidy range, then you would have to pay that full amount. So yeah, no, that could be, some people consider that being priced out. But for a family of two to not be eligible for a premium subsidy, they have to make over $64,000 a year. So you could also argue if you make $64,000 a year, you could afford a $700 a month insurance premium. But it's all relative, and it's all based on perspective. So,
my second question has to do with when the subsidies are distributed. Does it come in the end of your tax credit, or is it done monthly? Great question. So it's how are the subsidies distributed? And as I mentioned, most people are going to do it one way, but there is a second way you can do as well. Most people are going to get the subsidy check is going to be sent to their insurance company every month along with the check that they write as well. And those two checks are going to meet and make up their premium. If you could pay your full premium, you could do that every month and then get your subsidy as a tax kind of refund or a tax credit at the end of the year when you file your taxes for the next year. But we think most people are probably going to do it on a month-to-month basis just simply because affording insurance has been the problem and the subsidies are going to make it easier. The one thing I will add on is that
the subsidies have to be reconciled with your income when you file your taxes the next year. So if you say you're going to make $40,000 and you get a subsidy based on $40,000, but you end up making $50,000 and you don't call to kind of correct that middle of the year when you figure that out, you're going to actually owe back some money at the end of the year because you got more of a subsidy than you should have gotten. And it works the other way as well. If your income went down and you're getting too little of a subsidy, you would get a bigger refund or a bigger credit at the end of the year. So, sure. Sure.
You talked about subsidies and how people have an option to either pay it up front immediately or wait till the end of the year.
Yeah.
Is there a way to regulate to make sure that they would use those monies for their subsidies rather than maybe go out and buy them?
Well, the subsidy actually doesn't go through the family. Doesn't go through the individual. The subsidy goes from the Treasury Department directly to the private insurance company. So it doesn't go through the family at all. So in that case, it kind of eliminates that potential for abuse that you have there. The check, the family writes a check, and the Treasury writes a check, but the Treasury check goes directly to the insurance company. So there's a question right here, I think. Yes, ma'am? Sure. So the open enrollment period now is between now and March 31st, and that's for 2014. If you wanted the same kind of Obamacare insurance in 2015, you would need to sign up again, as I mentioned, between October 15th and December 7th of 2014 would be the open enrollment period for 2015. So it's sort of like if you work for a company. Most companies have an open enrollment period where you go and you sit down with your HR person, they give you the packet of the smiling, happy, insured people, and you sign up for that insurance. So that's basically what it's going to be. Every fall, there's going to be a new open enrollment period. You can change plans, at that time, or drop it entirely. You could even drop it in the middle of the year. Let's say you have the Obamacare insurance, and then you get a job that provides you with insurance. You can cut that off and then start your employer-based insurance that next month. Or if you lose that job 2 months later, you can go right back on to being on Obamacare. There's no waiting periods. There's nothing like that. You can just start it or stop it if you have one of those life changes. But if you don't have a life change, like a job loss or a birth or a marriage or something like that, then you sign up during the open enrollment periods every fall. Yeah. Sir?
Just another question. You talked about how the ideal of this new healthcare system is basically to shift away from specialties and more towards primary care as well as VAs. Is there any talk about concern of the quality of care being decreased since essentially your schooling and your specialties are being decreased in a particular field?
The question was, with the additional emphasis on primary care, is there some concern that we could be losing quality in the specialty care that's being delivered across the country? Surgeons, dermatologists, people like that. Well, I don't think there's going to be any less investment in those fields because they actually kind of pay for themselves. What it is going to be more government investment in primary care. Not that they're going to be taking away from specialty care and delivering that to primary care. They're just going to be adding more investment into primary care through loan reimbursement programs for people going into it, more community health clinics that are being founded, trying to expand medical school classes to bring in people who are going to say, I'm going to go into primary care, from the very beginning. Whole medical schools devoted to primary care kind of specialties. So I think it's more of an addition than it is a subtraction and an addition for that. I think specialty care are always going to be an essential part. And in fact, a lot of specialists kind of grumble a little bit about the Affordable Care Act, at least the ones I talk to. But what's interesting is that uninsured patients could generally afford going to see someone like my wife, who's a primary care doctor. She might charge them $200 to get a splint, or a couple $1,000s to deliver their baby. And usually people can afford that. You save up, you can do that. Someone needs brain surgery, chances are they don't have enough money in their bank account to go self-pay brain surgery that a brain surgeon would deliver. So if more people are insured, that means there's more people who actually are going to be able to go and get brain surgery. So you'd think that there'd be more customers, more insured customers for those specialists than there used to be. So in some cases, I think specialists are going to see more paying and reimbursed customers as opposed to more of the charity care that they give in addition to the paying customers that they also work with. Follow up? Yeah?
Sorry, I'm going to keep going, but I guess my concern with that is
Yeah.
giving your opinion, is even though you're increasing the amount of, let's say, operations that you're doing, you're decreasing the amount that you're getting paid for that operation. So do you think it'll turn into kind of a land down, clean demand type of an operation, that they're just going to crank out as many as they can as fast as they can without having the quality of care present?
Yeah, that's kind of, the question was, are the reimbursements going to come down for specialty care to make it, more of like an assembly line type of operations, and so specialists are just going to try to get in as many people as they can and not worry about the quality as much. That really depends on the incentives or disincentives of the reimbursements. If you start seeing, and I don't think we've seen this yet, reimbursements for brain surgeries or other kind of surgeries starting to come down, then yes, I think that could be a challenge. That all of a sudden specialists are not going to be compensated as well. It's going to impact their bottom line, and so they're going to have to, think of something else to do, more patients, less quality, sort of bending the curve that way. So I don't know. To be honest, I guess you have to follow where the money goes. Medicine works by incentives and disincentives. If you have a $50 copay, you're not going to run to your doctor because you got a nosebleed. If it was a $2 copay or no copay, you might do that. The copay is there as an incentive or a disincentive to get you to do something. And it works for providers as well. They have incentives and disincentives built into their reimbursement rates that they all know pretty well. And so if those are changed to sort of, discriminate against specialists, then I think you could see something like that. You could see more people go into boutique medicine, where they don't take any insurance plans, and people pay a $10,000 retainer to be on call for those, those clients, and, everything's cash. And you can see more doctors doing that. You already do see that a lot going on right now. So, yes?
So, how or when are they going to enforce the penalty for not being insured?
Got it. Sure. So the penalty for not being insured for individuals is in effect for 2014. And basically, if you don't have insurance by March 31st, and you don't have insurance, in other words, you haven't purchased the insurance by the end of the open enrollment period, and you remain uninsured for more than 2 months during 2014 beyond that, then you'll be liable for the penalty. So it really kind of goes all the way until May is when that could be. You could be uninsured up until May. Then it'll be assessed on your taxes. So there's going to be some new numbers on your 1040 that say, are you insured? And you say yes, and then you put in your provider number or whatever that is from your insurance company, or your Medicare or Medicaid number, and then you're okay. If you're uninsured, then they're going to be like, okay, well, how much did you make last year? And if you make over 100% of poverty, and you don't fall into some of the other categories of religious exemption, or undocumented immigrant, or a lot of other kind of categories, then that'll be assessed on your taxes. So there'll be that $95 or whatever it is based on your family size. The thing is, when they wrote the law, they didn't put any enforcement into that. So, I don't know if I should be saying this, but you don't have to pay it. I mean, it basically will be baked into your taxes, but you could write a check for that lesser amount, and there's no enforcement within the law that they can provide a lien or come after you or anything like that. So, that was one of the ways that they had to get the law through Congress, was not having any enforcement mechanism. But it would be added onto your tax bill. Oh, that's a year. That's a year for 2014, and then it moves up to $325, and I think $695, 2015, 2016, and that's just for an adult, for a single person. It's a little more complicated than just 95. The max is $285 per family. For that, kind of adding it up a la carte, or 1% of your income, which is ever higher. So, yeah.
How does this system compare to other systems like for socialists, like Canada's?
Sure.
Because one problem I know with that is because more socialist medical or healthcare systems is having to wait so long to receive the care.
Yeah.
Everybody has coverage, but it was waiting months for surgery or operation. So how does that compare? Do you see us ending up like one of those systems?
Great question. So the question was, do we see the Affordable Care Act, Obamacare, how close is it to a socialized medicine system you might find in Canada or France or Switzerland, Germany, many of the other industrialized countries that have it? I've got a little bit of perspective on that. My wife went to medical school in Quebec at McGill, and medical school there. I lived in Great Britain for a while, so I've sort of seen the national healthcare system. So I can definitely say that the Affordable Care Act is nothing like national healthcare. What it does is, you notice all those people getting insurance on the marketplace, they're not really getting government insurance. They're getting private insurance. It's going to bring several tens of millions of new people into the private insurance market. There will be people joining Medicaid, for sure, sort of new folks coming onto Medicaid, which is government insurance, but the majority of folks are going to go onto private insurance. So in that case, it's kind of pushing us further away from a socialized medicine system, in that we have more people joining private insurance markets. They're getting subsidies to do it, but the medical care, the doctors, all that is being delivered through private insurance. So in that case, it's not really moving in the direction of socialized medicine at all. Although some people argue the subsidies are sort of like an and run around that to get people into it. In France, I'm sorry, not in France, in Canada, you do have national health care, where everyone has a national health card and everybody gets a basic level of service. If you work for a company, they can provide extra tiers of health care on top of that. And it really is a provincial system as well. So the healthcare in Ontario, hopefully there aren't too many Canadians here I'd be upsetting. The healthcare in Ontario is actually pretty good, BC, those places. Quebec, where my wife went to medical school, it's super highly regulated, and it's actually, you do have those waiting periods and you do have those lines. And partially is because they say we're only going to have 10 doctors in this neighborhood. And even if there's a need for 20 doctors, the provincial government says, no, we can only have 10. And so that's where the waiting lines get. It's a very highly regulated system. I don't think we'll see something like that happening in America, where you have a lot more of the free market, open your clinic, open your doctor's office where you want kind of thing. So in that case, I don't see it approaching socialized medicine. The equivalent in the United States would be single payer, which would be, you probably heard the discussion about single payer versus Obamacare. It came up during the 2010 discussion of what should go into the law. There's some concern that if Obamacare fails, the website doesn't get fixed, there's a lot of shenanigans going on around the cancellations and things. If it goes down in flames, then 10 years from now, what's going to be on the table is going to be single payer, because it's really going to be the only system to bring it back. And actually, if we wanted to address the cost issues and things like that, that I mentioned earlier on, single payer is really the best system to do that. It was the system that would bring our costs down the quickest, in addition to bringing people into coverage. But that's not what Obamacare is. It's private insurance, polyglot system, 5 insurance companies here in Utah, all over in Weaver County, all doing their own thing. So we're not there yet, but I just wanted to mention that you'll probably start hearing single payer mentioned as an alternative if Obamacare falls. Maybe not immediately, but years down the road. So, right here, sir.
I don't know if this just applies in Utah or throughout the whole U.S. Are there health insurance companies that are going to be not under the umbrella of the Obamacare, such as those 6, so that someone can decide, I don't want to pick one of those 6 or however many there are in the Obamacare system in Utah?
Great question. So the question was, are there insurance companies that are going to be offering insurance products outside of the marketplace that we described? Absolutely yes. And in fact, all of the insurance companies in the marketplace are going to be offering plans outside the marketplace as well. Often they're the same plan, or just slightly tweaked, slightly different. But all those, there's going to be a robust private insurance market outside of the marketplace as well, continuing to be. The thing is, you can't get subsidies if you go through that private market, because you can only get subsidies if you go through the marketplace. So let's say you make $300,000 a year, no chance you're going to get subsidies. So you could go through the marketplace if you want, or you could just call up a private insurance company and go get insurance that way. All those plans are going to be there, all those and providers, and there's going to be a couple more. Aetna and United Healthcare decided not to participate in the Utah marketplace, but they're going to offer plans in the private marketplace out there. So there's going to be some more choices available as well. So yeah, the private insurance market is still going to be out there, but it's not the place to get subsidies if that's what you're interested in. Yeah, I had someone come to our open house who makes $5 million a year, talking about this. She's one of the big mommy bloggers in the state. And I was like, yeah, I don't think you need to go through the marketplace. You need to have about 11,000 kids to qualify. So, question over here, right here, sir.
Will the Affordable Care Act ever regulate doctors' income?
No, I don't think so. Let me step back at this. Doctor's income is really based on a couple things. It kind of depends where you work. If you work for a federally qualified health center, it's partially based on what your starting salary is there and the RVUs, the revenue relative value units that you produce, how efficient you are. If you work for a private clinic, it's often based on salary and also your productivity. Usually there's those two mixtures in there. If you work for a hospital, you're a hospitalist, oftentimes it's a set salary. There's actually no product because you do shifts, so you're like an ER doctor. I'm pretty sure they don't have RVUs at ERs, because if no one gets shot the night you're working, you still get paid. So I think there's still going to be that kind of diversity of how doctors are paid. And the only thing I could think about it is if there's a better investment in primary care, then there could be people working at the federally funded health clinics. The federal government could say, we're going to pay primary care doctors at FQHCs more, so it's going to increase their salaries in that regard. The other thing it could do is that they could say, we're not going to, the medical evidence says that if you do colonoscopies before age 50, it's not medically necessary. So a certain doctor has built his whole practice on doing colonoscopies before age 50, is all they're going to find that Medicare and Medicaid aren't going to reimburse for that anymore, that could affect their income, so they'd have to shift in that regard. So there's probably a lot of ways that it does, but it's probably not the way you might have been thinking, which is that there's going to be some bureaucrat that says, we're going to pay this doctor $10,000 less, and then put it onto a spreadsheet kind of thing. So, but yeah, great question. It's very complicated. As I found out through talking with my wife, it's, how doctors are paid is as complicated as how lawyers are paid, really. Yeah?
So you said that the people that get penalties if they don't get the insurance,
Mhm.
they kind of put money in the pot, but then also hospitals are $60 billion or whatever getting
Mhm.
cut. So is any of that money that, uninsured, is that going to find its way back to the doctors or the hospitals, or they just go out and that money's going to the government?
Gotcha. So the question was, so the people are paying their penalties because they're not getting insurance, and so where's that money going, and is it going to help compensate the doctors and hospitals that are still providing some of the charity care because their money's being cut as well? Boy, to follow the money would be pretty hard. It really does all go into one big pot. So the money that people pay for penalties is going to support kind of the whole infrastructure of the Affordable Care Act. Paying for setting up the marketplaces to reimbursements to everything. I don't think there's any directed saying that it's going to one kind of thing. In terms of will it go back to the providers and to the hospitals, I think it will in kind of a roundabout way. It's because those doctors and hospitals write off a lot of what they do as charity care, as uncompensated care. And so if more people are encouraged to get insurance by having the penalty out there, and this is a little bit more about incentives and disincentives. Imagine if they didn't have a penalty, and everybody could do Obamacare or not. Then all of a sudden you have a lot more people who say, I don't want this insurance. I'm going to go and I'm going to trust my luck. And if I get into trouble, then maybe I'll pay my bill, but maybe I won't. But now that they have the penalty, there's people who are going to be like, I don't want to pay the penalty. It makes getting insurance more lucrative, so they're going to go get they're going to go get insured, which is going to increase the compensation that's coming to doctors and to hospitals because they no longer have to write off the debt that person would have just walked away from. So that's sort of an answer that I can give you, is that the penalty encourages people to be insured, which increases the compensation that comes to doctors. That's about as close a correlation as I can get to. In terms of where it goes in the big pot, boy, it's messy. If you think my slides are messy, you should see CMS's slides when they try to explain how this works. I don't think you can say that the money is going directly to the doctors. The only way I could say it would be loan forgiveness programs and things like that are directly targeting providers, are being funded through money that the Affordable Care Act is appropriating. So, in purple, yeah.
With the exemptions on these fees, what kind of relief?
Sure, yeah, I didn't get into that. So the people who are not required to purchase the Affordable Care Act insurance and would not be penalized are, if you earn less than 100% of the federal poverty level in Utah, that's specific to Utah because of Medicaid expansion, you don't file taxes. You're under the $10,000 threshold, or you just don't file taxes. You're undocumented, because you're not eligible if you're undocumented. So, they're not penalized as well. If you are a Native American, it's not whether you use IHS. I learned recently it's whether or not you're a Native American, and you're not required to do that as well, because there's other options out there as well. If you are a member of a religious organization that kind of pays for its own health care, and that would be monks, sisters, people in those kind of organizations, or you're a member of a special group like the Amish. I used to live in Pennsylvania, so the Amish are in a group that they have kind of a community-based healthcare system where everyone pays in and then they pay out. They're not required to do that as well. The organization has to have existed, I think, before 1950. So it's not like you can invent an organization or a religion right now and qualify. So there's some sort of grandfathering that has to go in. Again, that's, there's 100,000 people in Lancaster County where I used to live who are Amish. That's probably the majority of people who are going to be exempt under that category, or right there, or in Ohio. So it's not a huge population. Prisoners, people who are incarcerated, are also exempt from it. I'm trying to think if there's any others. Oh yeah, if you live overseas more than 330 days a year, you're exempt from it as well. But if you come home for more than 31 days, then you do have to have some sort of insurance for that. But if you're an expat and you live overseas for more than 330 days, then you're exempt. And there's probably a couple others I forgot, but those are the major ones. Most of the ones are going to be income. If you make less than 100% of poverty, or you're undocumented, then you're not going to be penalized. Other questions? Yeah?
For the federally funded community health clinics, how is the funding going to change for those if more people have insurance? Will there be, everyone's supposed to have insurance then
So the question was, how is the funding, and let me tell you if you got this right, how is the funding for the federally qualified health clinics, the CHCs that I mentioned, how is that going to change if more people are getting insured and they've been serving as kind of like a social safety net for people who are uninsured, as well as people who have insurance? That's a really good question. The FQHCs serve a pretty diverse population. They serve insured, they serve uninsured, they serve documented, undocumented. They kind of have a mix, and each CHC has a different mix based on the geography that they're in. And I wish I had someone from the agency here that could probably explain it better. So if they get more insured patients, either through Medicaid or through insurance, that just means that the people are going to be paying their bills through insurance as opposed to paying it through a sliding scale. Because everybody who walks in, unless you have nothing, is required to at least put $15, $20, $25 down. It's a real sliding scale depending on your income for the care that you receive. So they could be getting more money if people have private insurance or if they have Medicaid. So does that mean that they're going to get less government support? It could be. The government could start actually ratcheting back the amount of support they get. But what we've seen, though, is that Utah's gotten about $4 million of extra investment in the past couple of years to create more clinics. So if that support starts to be taken away, it's certainly not happening right now, and what we're seeing is that there's a lot more investment in putting in these clinics in the high-need areas like South Salt Lake, Vernal, places that really haven't had this kind of access to healthcare before. So I could conceive it, that in other words, sort of like hospitals are losing their charity care payments because they're getting more insured patients. You could see that the FQHCs could lose some of their federal funding because they're getting more insured patients. I just haven't seen anything about that, but you could follow that logic and say, yeah, that could happen. So, yeah.
Is there anything being done to address the two other aspects, quality and cost of healthcare right now in the United States? If not, and also what do you think is the best way to address those two?
Right, those are the what is being done to address quality and cost. The three pillars that I showed early on, Affordable Care Act focusing on enrollment, but quality and cost are sort of the other two things to work on. There are. One of them actually is death panels. You guys all remember death panels? Death panels was all about improving quality and controlling costs, not by taking grandma out to the parking lot and shooting her, as many people thought, but by creating what's known as the IPAB, or the Institutional, IPAB Advisory Board of the last two. I think it's Institutional Performance Advisory Board or something like that. That was a board, a national board, that was supposed to say, hey, if you invest a certain amount of money in this kind of care, it's going to create cost savings across the entire spectrum. Here's an example. If you give someone an aspirin when they come into the emergency room with chest pains, the chances that they're going to need an angioplast, getting one of those little tubes that go through their arteries, or the complexity of that angioplast go way, way down. Just by giving them a little aspirin as soon as they arrive to the emergency room. Or if they need an angioplast, getting it done within the first 60 minutes of when they show up and present, as opposed to waiting an hour and a half. The mortality rates, the things like that, go way up the longer you wait. So they figured that out in Florida. They have a lot of old people in Florida, so they figured that out. But they knew that in Florida, but they didn't know that in Oregon. They didn't know that in California. So the IPAB is designed to create incentives that say, hey, emergency room, if you give your chest pain presenters an aspirin, we're going to give you $5. That more than pays for the aspirin, even in a hospital, where the aspirin usually costs $3. And so there's that incentive for the hospital to do that. They get paid, and then the government likes it because all of a sudden, if they don't have to pay for as many angioplasts or as many heart attacks, then they save money down the road. So that's how the Affordable Care Act is slowly moving into cost containment through the death panels, through the IPAB, to sort of do best practices for healthcare, get that out to people, create the incentives, and other things that are disincentives, like in McAllen, Texas, they have some of the highest healthcare costs in the country, and it's because all the doctors were working together, realizing that they could, if they all did it together, then they could really increase their revenue and increase the amount of money they got, and run all these tests and all these things that were completely unnecessary. And as long as they all did it, then they all wouldn't be, no individual person would be in trouble. So Atul Gawande, you guys know him, the New Yorker writer who writes about healthcare issues, he went down there and sort of looked at why McAllen, Texas had the highest healthcare costs and federal reimbursements for Medicare and Medicaid in the entire country. And what the IPAB could do is say, hey, all those unnecessary tests you're running, we're not going to pay for them anymore. And so that's a way that they can cut the costs as well. bring it down into what the national norms are for providing care.
So the iPad is in state right now, and it's something that's.
It's not. It's not. It's sort of in dormancy. And remember what happened with death panels? They put it in and then they took it out, and they put it in and then they had to take it out again. So it hasn't yet met. It hasn't yet officially gone into what it's supposed to do. Part of it is that it has to wait for Congress to do some actions, and that hasn't come from Congress yet. So unfortunately, it's a little bit bogged down, or fortunately, depending on how you view it, it's bogged down by some of the politics involved. But that was the aim of the iPad, was to control costs through incentives and disincentives. Through very simple things like giving someone an aspirin when they show up with chest pains. So simple, but hard to do across the country. Other questions? That was a great question. Anything more? How many folks are going into the medical field, do they think? Healthcare providers. How many people are in education, medical education, things like that? Okay, yeah. How many people are interested in Obamacare insurance? Okay, all right, so we got some folks here too. So, there's a little bit of overlap there. I mean, one thing I say is you do have healthcare insurance through your parents up till age 26. You can stay on that. Or if you have university healthcare insurance, I'm not sure if Weber State provides that, that will also cover you. You won't be penalized if you do that as well. So that gives a lot of students a little bit more time to make the decision. And hopefully the website a little bit of time to get fixed as well. So there's no more questions. I'll be glad to hang out here. Was there a question? Or?
Let's see, I guess I would like to know,
Let me do that real quick. Do you mind if I'll do a quick summary. Medicaid expansion is the major policy issue that faces Utah right now. When the Affordable Care Act was set up, it was designed to be this puzzle that worked together. People would be covered from Medicaid from 0% of poverty up to 100% of poverty, or even up to 138%. There's a bit of an overlap. And then the subsidies would cover folks from 100% of poverty up to 400%, just like that chart that I showed, all the income levels there. It was meant to be a meshed system to cover a lot of people who had either no access to health care or weren't able to afford the access to health care that they had. This was how the law was written. Then along comes the Supreme Court in 2012, and they allowed the Affordable Care Act to survive. Actually, go back one more. What they did is they broke apart the puzzle. They said that Medicaid expansion is now optional for all states to pursue. So what it does is it leaves people from 0 to 100% of poverty up to the whim of the state about whether or not they're going to do Medicaid or not. So far, about 25 states have decided to expand Medicaid, and 25 haven't, or some are like Utah, and actually still in the decision process. So the subsidies are intact for people who make from 100 to 400%. That's still there, the helping people out with their monthly premiums. But if you make under 100% of poverty, and your state doesn't expand Medicaid, then you're really left with many fewer options, because you can still buy the marketplace insurance, but you can't get the subsidy. It's kind of a weird thing. If you make 102% of the federal poverty level, you're going to get a really, really generous subsidy to buy that insurance. If you make 98% of the federal poverty level, you get nothing. So you can still buy the insurance, but you don't get the subsidy. It's because it was all set up, like the previous slide, to kind of have this system of Medicaid intermeshing with the private insurance subsidies. So that's kind of where we are in Utah right now. We haven't expanded Medicaid. It's still on the table. Actually, there was a big article in some of the newspapers today about sort of the governor's plans on that as well. But that's where we are. If we could jump ahead. What it does is it leaves about 123,000 Utahns in this gap, this group of folks who aren't going to qualify for the subsidies and can't qualify for Medicaid right now. Because in Utah, Medicaid is a categorical program. You have to be low income, but then you also have to be in another category to qualify for it. So you have to be a kid. Kids are covered under Medicaid and CHIP up to age 18, up to 200% of the federal poverty level. So a lot of kids in Utah get covered, which is great, because we have a lot of kids in Utah, and getting them health insurance is universally deemed to be a good idea. You can be pregnant and get health insurance. You can earn up to 133% of the federal poverty level. 2 months after you give birth, you're probably going to lose it. Your kid will have it, but you won't have it anymore. But it does provide prenatal care to women who are pregnant, including undocumented immigrants. They get emergency Medicaid to cover their delivery. They don't get it to cover their prenatal stuff, but they do get it to cover their delivery, which is important. If you're an adult over age 65, you're a senior, you can get Medicaid if you earn under 100% of the poverty level. You actually get Medicare as well. So you get Medicare and Medicaid if you earn under 100%. Or a person with a disability, you can get Medicaid as well. But the big gaps are adults with children and adults without children. If you have children, you can get Medicaid if you earn under 50% of the federal poverty level, which is about $5,000 a year. If you earn under that, you can get Medicaid. If you're an adult without children, you can't get any coverage whatsoever. There's no Medicaid for single or married adults without children in Utah. So that's really the majority of those 123,000 Utahns that are in the gap are in those top two categories right there. If Utah expanded Medicaid, this is how it would look. People would be eligible for Medicaid, especially adults without children and adults with children, up to about 133% of the federal poverty level. There'd be some boosts for children and for people with disabilities as well. So there'd be a lot more people who would be given this option. The state of Utah actually did a study that pegged it down to 123,000 and actually looked at the costs involved and things like that. So that's sort of the information we're dealing with. But we haven't decided yet. Utah is still in the sort of political process of trying to figure out whether Medicaid is something that, the Medicaid expansion is something that we want to do. And it's very complicated in our state because it's not only a governor decision, but the legislature also has to play a role because of a law that was passed last year, saying that the legislature not only has to appropriate the money, but actually have an up and down vote on it as well. So that's sort of where we are. The governor came out yesterday and said he's not going to put Medicaid expansion into his budget for 2014. He wants to sit down more with the legislature and kind of work this out. So the earliest it could happen in Utah would probably be 2015, which means we'll lose a whole year of a pretty generous federal match, which I'll describe in a, actually, can you skip forward one? Sorry. Because the federal government pays 100% of the expansion cost for 2014, 15, and 16. It's supposed to be a carrot to kind of get states to come in and do this. And actually what it would cause Utah to actually earn money by expanding Medicaid. We get a lot more money than we would be getting right now. After 2020, that federal match drops down to 90%. The federal government pays 90% of the cost, the state pays 10%, which is still better than our current matches where the federal government pays 70 and the state pays 30. Medicaid policy is a crazy subject. I'm really glad that Riley, my colleague, is in the back of the room, so she's our Medicaid specialist. You can shout out if I get this wrong, okay? Is that all right? Am I doing good? Okay. What it would be, though, is if Utah actually expands Medicaid, it would end up costing the state about $25 million a year in extra costs. So it is an expense, and that's one of the things that Utah is debating. Is it worth it to spend $25 million or $35 million a year to add insurance to an extra 123,000 people? And that's really one of the big issues. The other is that there's always been some suspicion of federal programs and government programs in this state, and Medicaid certainly falls into that kind of a category. And so there's some other kind of resistance to expanding Medicaid just beyond the fiscal cost of it. Some of the states that have expanded Medicaid include Ohio, Arizona, and New Jersey. If you notice, those are all led by Republican governors. So it has really stopped becoming a strictly red state, blue state issue. It's really a state-by-state issue based on looking at the numbers and seeing what can get done legislatively and in the executive leadership of each state. Jump to the last slide. Yeah. So this is how the country actually looks. Utah is kind of leaning towards no. I think we actually are maybe a little bit more purple now based on some of the new news we got. But the blue states are the ones that are expanding Medicaid. The dark red states are the ones that aren't. The sort of middle ground states are the ones that are kind of in the middle trying to decide. And if Utah were to expand Medicaid, if it were to happen, it would actually be a lot like what's probably going to happen in Arkansas or Iowa, which is what is known as a hybrid model, which is instead of doing a full expansion like they did in California or other states like that, we would give Medicaid to certain groups of folks, maybe up to 100% of the federal poverty level, and then we would actually give subsidies for the rest of them to get private insurance in the private market. So it'd sort of be extending the Obamacare subsidies down to a smaller or larger group of people. And it could even divide it up based on substance abuse or age and things like that. They could slice the pie a couple different ways. So that's what Utah, if we were to do it, it would probably be like an Arkansas model is what they call it. The challenge is that those models usually end up costing more. Medicaid, just traditionally expanding Medicaid is the most efficient way to do it. But in some states where that's politically not possible, these other alternatives have gotten approval from the federal government, but they end up costing the state more money. So we'd be paying to do something a little bit more unusual if we decided to do it. Currently, as I mentioned, about 25 states, this is a little bit outdated, sorry, from September, 25 states are leaning for it. The latest one was Ohio. where Governor Kasich there kind of went around his legislature to get it done about 2 weeks ago. If you could go back one slide. I'm sorry, I'm kind of jumping. One more, actually. So these are the options that are on the table right now. Full expansion, hybrid expansion, which is that Arkansas model, charity care, which is something that certain groups here in Utah are very interested in doing, block grants, or doing nothing. The one that I think could have the biggest sort of chance of success would be the hybrid expansion model. Again, the kind of giving some people Medicaid and giving other people subsidies to get private insurance. What it would do is it would bring that extra 100,000 people into the insured system. So because right now when we go out and we do enrollment events, we have people come up to us and we plug their numbers into the computer, and if they make 110% of poverty, there's a big smile on their face because they know they can get the Obamacare insurance and get a generous subsidy to afford it. But if they make 95% of poverty, we have to kind of explain to them, I'm sorry, there's no options for you right now. And they get pretty upset because they thought that this was going to be something that could help them. And it actually, right now in Utah, isn't. So, what do? Go get another job, try to boost their income, move to another state. Those are the options that are available for them. But until Medicaid is expanded, there's not going to be the insurance option, at least presumably an affordable insurance option that they can do. There's a lot of controversy around this, a lot of politics around it. What we try to do is we try to focus on what are the fiscal arguments, both in favor of it and against it, and try to deliver that advice through the presentation. But sometimes it's hard to ignore those people who come up to you and fall below the threshold and realize that their family isn't going to get insurance because of this. So, that answer your question? Any more?
When you talk about Medicare Medicaid,
Yes, I make that mistake all the time.
what is it that they're expanding what is it?
Sure.
Medicaid does not allow a lot of things.
Yeah.
What is it that they're going to do to coverage?
Great question. Expansion probably isn't the right word. Basically, by Medicaid expansion, it means expanding the number of people who can qualify for Medicaid. Because right now in Utah, you not only have to be low income, but you have to be pregnant, disabled, senior citizen, a child, or a parent. So you have to be one and the other, a categorical program. Expansion gets rid of those categories. So it says you just have to be low income and you can get Medicaid. It doesn't matter whether you're pregnant or not pregnant or anything like that. You're just in the Medicaid bubble at that point. So that's what the expansion is. In terms of the benefits it provides, there's really no changes to that. The Medicaid expansion is really just about enrollment, just about expanding the categories of people who can get into it. So one thing that Medicaid expansion does do, or it's sort of related to it, is that reimbursement rates for Medicaid have risen for the past couple of years to be on par with Medicare to get more doctors and more providers to accept Medicaid patients. Because that's always one of the challenges. Even if you have Medicaid, there's a lot of doctors that don't accept it. So, because its reimbursement rates are lower than private insurance. So that's one change in sort of the provider side of things. But mostly it's about bringing more people into it. Other questions about it? We'll know within the next couple months what's going to happen. Governor Herbert's going to come out with his budget in December, probably not have Medicaid in it. Legislature meets in January. It's going to be a big issue there. There's some bills that could potentially be run. And so I think by about April, we'll have a lot more knowledge. And if we don't, I'll be a little bit sad because I've been saying we're going to know a little bit more for the past year. And we never seem to actually get around the corner to see it. But this time, I'm telling you, this time it's going to be there. So we'll find out. Riley's laughing because she's been through this crazy thing as well. Any more questions? Yeah.
So like as a take-home message, would you say the Affordable Care Act is a good thing or a bad thing for Utah and Americans? And also is it a good or bad thing for healthcare professionals?
So is the Affordable Care Act a good thing or a bad thing? That's really the crux question, isn't it? Okay. I would say the Affordable Care Act depends on your perspective. If you are someone who has never been able to get insurance or afford insurance, if you've been denied because of your health history, then I think it's a good thing because all of a sudden you're going to be able to get insurance, you're going to be able to afford it, you're going to be able to cover yourself and get the care that you need. But let's say you're one of those groups that got a canceled plan and you go into the website and you try to shop for new insurance and you find out you'll be paying much more for your insurance. You're outside of the subsidy bubble. You make too much money to be a subsidy. You were getting insurance for $400 a month and you liked it, and now you've got to pay $700 a month for your insurance. those people would probably say, boy, Affordable Care Act is not a good thing. Even if it's helping out my neighbor and my friend, and maybe it'll help me out 10 years down the road, it's certainly not a good thing right now. So it really depends on your perspective. If you're a provider, if you're going into the healthcare field, well, if you're in the primary care field, like my wife is, you deal with a lot of patients who are uninsured. And you say, you know, that lump that you got, you probably should get that checked out. But if they can't afford it, then you just wish them good luck and send them on their way because they can't afford that follow-up that you need. So as a provider, that's probably pretty tough to do that over and over again, realizing that these people just don't have the money to go get these things checked out. If they come in and they have insurance and you can make that referral, sure, they're going to have a copay, they're going to have a deductible, but instead of $10,000, it's going to be $500. There may be something that they could work into their budget. So that, I think, for some providers is going to be helpful. But, you know, for specialists, it could be an up or down thing. I mean, some specialists make more than $250,000. In fact, a lot of them do. So they could be paying more money through their capital gains, high earners taxes. So some people could view that as a negative if you end up paying more taxes, medical device makers and things like that as well. So it depends on your perspective. From a global, or maybe not global, but from a national perspective, the more people who are insured, the more people who have access to primary care doctors and can go and get something checked out early as opposed to waiting for it to get much worse, that's better for the entire system. Because we have a system that says, okay, if you get sick and you have no other options, you can still go to the emergency room and they're going to take care of you. It just happens to be the most expensive place to get taken care of. And, you know, we don't leave people to die on the street. You know, that's something we've decided in our country we don't do. So they're going to get taken care of, but it's going to add a heck of a lot of waste and a heck of a lot of inefficiency to our system. So from a national or sort of a macro perspective, getting more people insured, giving them that access to care is probably going to help out the whole system altogether. No matter whether you're an individual winner or loser, based on how you view it in your checkbook or your taxes or your capital gains, globally or macro, it's going to help everybody out. I think. So that was a very political answer, but hopefully it got it across. So, sure. Yeah.
So the people that are in the community while you're out, they can't even buy over 100?
Oh, they can. They can. They would just have to, they wouldn't get a subsidy. Yeah. So, I mean, like, you know, if you're a 30-year-old, the cheapest silver plan in Weber County is, I think, what did I say, $190? So if you can swing $190 for that, then a month or premium, and you make, you know, $10,000 a year or something like that. It's kind of hard to imagine someone doing that, but they could. Maybe they could get help from a parent or something like that, so they could do that. There's also the catastrophic care option. You know, if the insurance, you can buy catastrophic care if you're under age 30, or if the premiums are more than all the other plans are more than 8% of your income. So you can buy that catastrophic care, you know, with the premiums are maybe $60 a month or $70 a month. It doesn't cover a whole lot, but at least gives you, you know, a little bit of financial security. So yeah, you can always go and buy it. It's whether or not you get the subsidy or you don't get the subsidy. The only people who can't go and buy it are undocumented immigrants. They're not allowed to use the marketplace. So, yeah, good question. Sorry. I appreciate you guys teasing out these things that I maybe glossed over a little bit. So, any more questions? Well, I appreciate you guys staying until the end of the show. I'll be around for a couple more minutes if you have any other questions you want to come up, but I appreciate you coming. And any of you guys are interested in primary care and FQHCs, I could also make some contacts for you guys there, you know, here in Midtown or even all over the state. So I'd be glad to do that. And thank you for my host from the, you know, the Pre-Med Society. I know you guys have an official name. It's the American Medical Student Association Weber State Chapter. So thank you guys very much for hosting us and for the departments from also hosting us as well. So, thank you.